evolving landscape of diabetes management, where evidence-based medicine meets individualized patient care. Over the next 90 minutes, we will hear from distinguished experts who will share their insights on emerging technologies, nutritional strategies, novel therapeutics, medical legal aspects, and practical management challenges in diabetes care. We are confident that the discussions ahead will be both informative and clinically relevant.
Every successful scientific session is guided by experienced mentors whose wisdom enriches the academic discourse. It is now our honor and privilege to invite our esteemed chairpersons for this session. It is Dr. B.K. Singh sir, Dr. Saibal Guha sir, to kindly come forward and grace the dais.
Thank you, sir, for joining us this morning and agreeing to guide the proceedings of this session. With your permission, may we proceed with the scientific deliberation of session 8.
Let us begin today's scientific proceedings with the topic obesity management in special population. Sir, may I request you to kindly deliver your lecture. It is up.
Mic on hai? Honorable chairpersons, distinguished delegates, ladies and gentlemen, and very dear students. Obesity is now a disease. It was not a disease until the pharmaceutical companies did not produce medications to treat obesity. So always remember, when we talk in a scientific session, you should be very, very critical in analyzing the data, both from the academic and the commercial perspective. But at the same time, you should never ever deny the real consequences of any medical state. And obesity is such an state. If you ever think of obesity, your mind will generally veer towards the cardiovascular diseases, cerebrovascular disease, sleep apnea syndrome, pulmonary embolism, increased risk of thrombosis, and so on and so forth. But you should also appreciate that obesity is also associated with a lot of other conditions like musculoskeletal disorders. An obese lady coming with osteoarthritis of both the legs, both the knees, and obviously the reason is not an intrinsic disease of the knee, but the huge obesity that she is carrying upon, right? Similarly, we have other conditions as is mentioned on this side, the alcoholic liver disease, non-alcoholic fatty liver disease, exacerbation of asthma, and the amount of anxiety and depression these obese people go through. We have to think obesity as a holistic condition, and we should also apply a holistic approach. Now again, a very common connotation is that we think that obesity is largely a disease of adults. But you will be amazed to know that now we are expecting that by 2030, 250 million obese children and adolescents are going to be there in your practice. They will be seeking guidance from you. And we also know that in patients who are more than 12 years of age and up to 18 years of age, that's the definition of adolescence, where pharmacotherapy is now available, it's very effective, but at the same time, it has to be always combined with lifestyle modification. We have very clear role of semaglutide, the GLP-1 receptor agonist in adult population with obesity, with or without diabetes, up to 2.4 milligram, which has not only proved effective in reducing the body weight, but also reducing the cardiovascular and the renal complications. When we have such a strong background, it's very logical to think that can we apply or extrapolate the same scientific basis for the adolescent population with semaglutide as well. And therefore, I'm going to present to you the data pertaining to semaglutide in the this adolescent population between 12 to 18 years of age, and this trial is called a STEP teens trial. This is the usual randomization, a 2:1 randomization, 2.4 milligram of semaglutide against placebo. And we know that when we give semaglutide to our patient, we start with the lowest dose of 0.25 milligram, and then we slowly escalate after every 4 weeks to 0.5 to 1 to 1.7 and finally to 2.4 milligram. It's very imperative to know that when you select a trial, the inclusion and exclusion criteria should be very clear. That should answer the question that whether a particular molecule is going to be safe, effective, and can be used in clinical practice for the benefit of your patients. So inclusion criteria is very important that obesity should be well defined, either the BMI in beyond 95th percentile, or even if it is more than 85th percentile, then it should be associated with one comorbid condition. If you fulfill all these criteria, then you are eligible for this STEP teen trial. And when you use 2.4 milligram or maximum tolerated dose of semaglutide, and then you look at the result, this is absolutely astounding. Look at the reduction in the BMI. And this is a huge reduction. If you look at the statistical significance, a p-value of less than 0.001, that speaks volume of the efficacy of this molecule in reducing the body weight. When you reduce the body weight, you always think how much body weight has been reduced, 5%, 10%, 15%, 20%, or what? 1/3 of the patient lose almost more than 20% of the body weight. More than 50% of the patients lose more than 50% of the patients lose more than 15% of the body weight. And even when you talk about just 5% or more body weight loss, it almost reaches 72%. So there is absolutely no doubt that semaglutide is very effective also in adolescent population in reducing the body weight. It will obviously reduce the cardiovascular risk markers as well, and the safety issue as compared with the adult population is exactly the same. But it's not the first GLP-1 receptor agonist which has shown this kind of result. Way back, I think 10 years, 15 years ago, liraglutide was another GLP-1 receptor agonist, and Saxenda was 3 milligram of liraglutide, which was not the anti-diabetic doses but anti-obesity doses of liraglutide. That also went through a similar set of trial and demonstrated a similar set of results. Based upon these data, it was very clear that now we can use semaglutide or any GLP-1 receptor agonist with proven benefit in adolescent population as well. But when you use a molecule like this in a patient population which is not diabetic, we are only talking of obesity without diabetes, then we should also like to see what is the impact, not only in terms of reduction of the body weight, but also towards the cardiovascular outcome. Now you have got a range of molecules like liraglutide, semaglutide on the left-hand side. Ozempic is semaglutide injectable, Ribelsus is semaglutide oral. Then we have dulaglutide, then we have a weekly exenatide, and then the combination of GLP-1 receptor agonist and GIP receptor agonist, what is called tirzepatide. Now when you look at the cardiovascular outcome trials, what do you look at? You look at 3-point MACE reduction, you look at non-fatal MI, non-fatal stroke, heart failure hospitalization, cardiovascular mortality, total mortality, and these are the parameters which are mentioned on the left-hand side. And then you look at the results, you would clearly see that liraglutide and semaglutide are two molecules which gives you possibly the best result. And it doesn't matter whether you give it through the injectable route or you also give through the oral route. Close to that is the result with dulaglutide. As you can see, all the green zones, they show a statistically significant benefit, and the white zones show neutrality. But there is no red line, no adverse effects, or no non-effect. Now you can ask me a question that whether a plain GLP-1 receptor agonist is better, a combination of GLP-1 and GIP, which is tirzepatide, which is better. Now the makers of tirzepatide, Eli Lilly, they have the Mounjaro. So when they developed this molecule, they did not compare it with placebo. This is very important to understand. All these results with liraglutide and semaglutide are against placebo. But when you look at the development of tirzepatide, the first set of results is against insulin glargine, and the second is against dulaglutide. And unfortunately, these trials were not as successful as the trials as you see on the left-hand side with liraglutide and semaglutide. But that does not necessarily mean that tirzepatide will not give you cardiovascular benefit, because here the comparison with an active molecule, and there the comparison was with placebo. So it's quite possible that if you do a trial where tirzepatide is tested against placebo, possibly you will get the same set of benefits. But at this point of time, we don't have any study like that. What about the other oral anti-obesity drugs? You know, you remember we had sibutramine, rimonabant, naltrexone and buprione combination, etc., etc. All of them went through the cardiovascular outcome trial and they were all negative. They were either stopped prematurely because of the adverse side effects, or they did not demonstrate any benefit. It was only semaglutide which demonstrated benefit, as you can see. Tirzepatide, now realizing that we failed on the comparison with active molecule, now they are also comparing with placebo, and the other newer drugs like cagrilintide, survodutide, etc., they are also undergoing cardiovascular estimation, and we will be eagerly waiting for the results of these trials. Not surprisingly, based upon the data that I just presented to you, now semaglutide is approved for use in this adolescent population between the age of 12 to 18 years. So if a childhood obesity case comes to you, based upon these data, you can safely use semaglutide. These are the FDA approval press reports which you can easily quote, and you should never worry about using this molecule. Orlistat and phentermine, we have a huge experience of using these molecules over the last 20 years when no other anti-obesity medication was available. They used to reduce body weight, but they were all besieged with a lot of side effects and they were not very patient friendly. So almost the use of these molecules are now stopped in clinical practice. What about tirzepatide? Tirzepatide also has not only been tested in the adult population, but the tirzepatide pediatric study, SURPASS-PEDS, is also available. And this is the inclusion-exclusion criteria. I will not go into the details because of the paucity of time. But suffice it to say that when you test 5 or 10 milligram of tirzepatide against placebo, and you are looking at the HbA1c reduction, it is close to 2% reduction, 1.8% reduction on average, which is very, very impressive. And it doesn't matter whether you are talking of getting a target of less than 7% or less than 6.5% or even a very strict target of 5.7%. And look at the BMI reduction. It is absolutely fantastic. So we are having a very robust reduction in the HbA1c reduction, and at the same time a very robust reduction in the body weight. And that gives you a lot of confidence that tirzepatide, like in the adult population, is going to be very, very effective also in the pediatric population. These are the key takeaways from the tirzepatide adolescent studies, and that again gives you confidence that like semaglutide, you can use tirzepatide in the adolescent population with safety. What about the use of these molecules in obese pregnant women? The one-line answer is you will not use, it is not approved. So I can stop my presentation here, but I will not. This is the broad statement that at this point of time, GLP-1 receptor agonists are not approved for use in the pregnancy. But you should know the current status, what is happening. And the few things that you should always remember, that in all the trials with GLP-1 receptor agonist, it didn't matter whether you are treating a premenopausal woman or a perimenopausal woman or a postmenopausal woman, the results were absolutely fantastic. So the efficacy does not wean away just because you have a different age strata amongst women. Polycystic ovarian syndrome, that's a very important condition amongst obese women, obese girls, and you can see a very impressive reduction both in the BMI and the waist circumference, and that's obviously going to help these girls in a big way. Very good data. Then you sometimes get some surreptitious data. How do you get that surreptitious data? Think of it, a lady who was taking GLP-1 receptor agonist or a combination tirzepatide for reduction in obesity or treatment of diabetes. And the patient was not counseled, and by chance the lady has become pregnant. So then, after becoming pregnant, the patient goes to the doctor, and then the doctor finds out there is pregnancy and says, "Arey, aapko to ye dawa nahi lena chahiye tha," right? So you can always study on that population and find out that whether the offsprings of these, you can say unwanted pregnancy, or let's say that it was not designed to have a pregnancy while the patient was on that particular drug. Now you would see that there is no increased risk of congenital malformation in these accidental pregnancies which occurred in those women who were taking GLP-1 receptor agonist. So this gives you some sort of confidence to you that in future you can set up a trial with these molecules to see whether it can be used safely in pregnant women or not. So that's the accidental finding, and this is the data comparing with metformin, insulin, sulfonylureas, or without any drug at all. Other very important thing is that when you have these two molecules, semaglutide and tirzepatide, one thing always remember that tirzepatide has got a mechanism of action that will reduce the efficacy of oral contraceptive. So any girl who is taking an oral contraceptive, and if is put on tirzepatide, then there is a possibility that she might become pregnant. The efficacy of oral contraceptive will go down. That does not happen with semaglutide. This is one important difference that you should understand. So in women with childbearing potential, no recommendation. Absolutely, you do not use at this point of time because there is no data. Similarly, in breastfeeding, it is not allowed. At this point of time, a big no for use of GLP-1 receptor agonist in pregnant population. Now coming to the last part of my lecture, this is the elderly population. Now what is elderly? The definition is very, very different. You have the physiological age and you have the chronological age. A 70-year-old person can be very fit and agile, and a 50-year-old person can be very thin, fragile, number of comorbid condition, etc. So for all the administrative purposes, economic purposes, you can define obesity beyond 60 years of age or 65 years of age or 70 years of age, whatever the government thinks. But for practical purposes, it's the physiological, biological reality of life which determines that whether you are an elderly or not. But cutting across this debate, if you look at the data which is available with semaglutide, now you remember the semaglutide approval studies were known as the SUSTAIN group of trials and PIONEER group of trials. PIONEER was done with oral semaglutide and SUSTAIN was done with injectable semaglutide. And you can see very clearly that whether we are talking about the MACE, which is the cardiovascular outcome, or HbA1c reduction or the body weight, in all of them, it really doesn't matter whether the patient is less than 60 years of age or between 60 to 65 or 65 to 70 or more than 75. Equal reduction in the HbA1c, equal reduction in the body weight, some differences in the cardiovascular outcome trial, better cardiovascular reduction if it is used in less than 60 years of age, less impact. But even if there is less impact, it doesn't mean that it doesn't make an impact. You can see here that it still makes an impact, but it does not reach a statistical significance. For those who are interested in research, why do I say that in less than 60 years, the first slide on the left, 0.56, it is statistically significant, and the next one between 60 to 65, 0.84, this is also less than 1, but this is not a statistically significant. Why? Can anybody answer from the crowd? The confidence interval is beyond 1, right? Beyond the line of unity. There the confidence interval was 0.37 to 0.84, so it is statistically significant, it is less than 1, but it is 0.56 to 1.26, and therefore this is statistically not significant. You should know these simple research ideas which will give you an impetus to analyze the data in a proper perspective. Similarly, when you look at the data between a SUSTAIN 1 to 5 study, SUSTAIN 6 and PIONEER 6 were cardiovascular outcome studies, and those trials were the efficacy and safety studies. And in all of them, the summary is that it really doesn't matter that whether we are talking about the HbA1c reduction, weight reduction, or the cardiovascular benefit, semaglutide, irrespective of the age, will continue to give you the benefit. As you can see here, less than 65 years, 65 to 75 years, and more than 75 years. The weight loss is almost the same. And same is the result with the HbA1c reduction. Again, this is a busy slide. You don't need to go. These are the step 1, 2, 3 trials. And in all of them, there is a similarity of the results. And when you have a result which is over and again repeated, that gives you a lot of confidence that this is the innate property of a particular molecule. And this is a comparison of semaglutide against dulaglutide. And that clearly shows that it shows greater improvements in HbA1c and body weight as against dulaglutide, irrespective of age, sex, diabetes duration, glycemic control, and BMI. So that gives you again a lot of confidence for using semaglutide. Beyond HbA1c reduction, now let's look at the data coming out from the cardiovascular outcome trials and the renal outcome trials. The CV outcome trial, the select group of trials, pioneer group of trials, sustained group of trials, and renal trial was the flow trial. What is interesting is that the average age of patients recruited in these trials is more than 60 years of age. So again, that will tell you that if there was a benefit, it accrued both in patients less than 60 years of age and patients who are more than 60 years of age. So cutting across the age group, you can see here there is a very clear benefit. Male or female, whatever the age, whatever the BMI, you can continue to see the benefit, which is all in one direction, showing the great potential of this molecule coming out from the renal trial, which is the flow trial, and the cardiovascular outcome trials. When you compare semaglutide with tirzepatide, this is called a SCORE group of trial and STEER group of trial. These are the real life studies. These are not randomized control studies. And this is called propensity matching. Does anyone know this term, propensity matching? In research, this tool is very commonly. When you have so many factors which can affect the outcome of a study, then what you do, you take all those factors, try to remove the other factors. That is called propensity matching. And once you have done the propensity matching, and then look at the data, and if it is still very effective, very robust, then you accept it with a much more vigor. So propensity matching was also done, and even after propensity matching, you can see here that in the SCORE study and the STEER study, semaglutide proved either to be very effective or even superior to tirzepatide. Why this happens, that's a matter of debate. We can go on debating about the finer nuances of the scientific reasoning behind that, but that is the data at this point of time, unless some other data emerges. So dear friends, I would like to conclude my talk by telling you that even in the elderly population, if you assess your patient properly, you initiate at the lowest dose, titrate according to the side effects or requirement of the patient, and when you assess the weight, it is not only the weight and the BMI that you should be looking at. I think today we are talking a lot about the skeletal mass. You know, this appendicular skeletal mass index. These are all within the realm of now, clinical practice. You can utilize any of these data and see how your patient is actually behaving. And at the same time, always suggest the lifestyle measures. When you use a GLP-1 based therapy, the patient will lose the fat, but at the same time, there will also be loss of muscle mass. So always encourage that your patient should not only walk, but also do resistance training, isometric exercises. Will increase the protein intake. That will ensure that the muscle mass is not lost, because we want the fat mass to go, not the muscle mass to go. This is vitally important. So with this, we are very safe to use this molecule in elderly population, and that gives us a lot of confidence. So I would like to summarize my talk by just telling one line, that like in the adult population, in the pediatric population, and in the elderly population, you can use GLP-1 receptor agonists like semaglutide with impunity, expecting a lot of benefits without increasing any side effect. Thank you very much.
Thank you, sir. Excellent presentation. And one thing I want to share regarding the Bihar chapter, and we have just started a program of assessment of behavior and lifestyle practices among the school-going children of 12 to 18 years of the age. And it is just ongoing trial, and we have selected the 10 districts of the Bihar, and 2 district results have already come as a pilot product of Purnia and the Patna. And we found that there nearly 3.2% of this group of population having the obesity, which is determined by the inclusion criteria, and 28% of the this group of patient having the physical inactive. So obesity, we are assuming more than 3.2% or something else, but we still the data is pouring. And it is very, very excellent talk by you, sir, that this semaglutide can be used this in group of the patient of the obese person without, what I mean to say that what are the side effects do you assume that if you are using the semaglutide in this pediatric population, or if you advise what
I
side
showed you
effect.
in that particular slide, there was no difference as compared with the adult population. No difference at all.
So we can use this semaglutide to this pediatric populations. And do you want any comment? Yes.
No comments, sir. Just one clinical suggestion from you, sir, because you've been using this molecule quite since a long time. What tips do you do to prevent the side effects of semaglutide in a patient, especially the GI side effects?
Yeah, that's a very practical question. When you initiate a patient on semaglutide, 2 minutes of counseling is vital, absolutely vital. If you simply prescribe and jaiye lijiye, then it's not going to work. First, you have to say that it's an incremental dosing. 5 level का dosing है, 0.25 से लेकर 2.4 तक पहुंचना है. It will take time and we cannot rush, because if we rush, your side effects will be more. आपके पेट में गैस बनेगा, हल्का फुल्का डायरिया हो सकता है. इसमें से किसी से आपको परेशान होने की ज़रूरत नहीं है, क्योंकि ये दावे के साथ कह सकते हैं कि ये 1 महीने के बाद आपको नहीं होगा. Because the clinical trials have shown that these incidence of these side effects dramatically goes down after 30 days. So this counseling is important. The second counseling is that you should not take big portion of meals. You can divide your meal into very small portions. So if a patient is on a GLP-1 receptor agonist, we always say कि आप 5 बार 6 बार खाइए, लेकिन इतना इतना करके खाइए. इतना करके खाइएगा तो ये जो गैस बनने की टेंडेंसी हो गई. And finally, the worst thing is that if you have not counseled the patient and the patient comes after 2 months, डॉक्टर साहब आपकी दवा को बंद कर दिए. क्यों बंद करिए? अरे भूख ही खत्म हो गया. Now think of it. भूख अगर नहीं खत्म होगी तो वेट घटेगा कैसे? अरे भूख तो घटनी ही थी, but you should have counseled that. वो जो 2 मिनट की काउंसलिंग आपको बताना है कि देखिए, जब आप ये दवा आपको पड़ेगी तो धीरे धीरे आपकी भूख कम हो जाएगी. तो आप चिंता मत कीजिएगा कि हमको कुछ हो रहा है, हमको कोई साइड इफेक्ट हो रहा है. ये इसका इफेक्ट है, ये इसका साइड इफेक्ट नहीं है. So these are few pearls of wisdom which you should tell your patient, which will help a lot. कि अच्छा ठीक है, डॉक्टर साहब तो बोले ही थे कि ऐसा होगा, तो कोई बात नहीं है. Once the patient know that this is likely to come, but if it comes out of the blue, then obviously it is not acceptable. Yes, sir.
On all the parameter, I am quite fit. Then is there any need for medication?
Yeah. When you compare an obese person who has not been treated or is treated with just lifestyle modification and is treated with drug, there is a clear difference in the outcome. And therefore, if you fulfill the criteria, like the criteria of more than 30 BMI without any comorbid condition, or more than 25 to 30 with a comorbid condition, it is clearly shown that in that population, the cardiovascular and the renal outcomes are much better as compared to without taking drug. And therefore, if cost is not an issue, then one should definitely take. Reduction in the body weight to your ideal body weight will give you long-term benefit. The problem is that because obesity, like many other, like even diabetes, is largely an asymptomatic condition. As you said, that if I am obese and I am completely asymptomatic, why should I take the drug? But the data suggests otherwise. The data clearly says that obese person with semaglutide, obese person without semaglutide have different cardiovascular and renal outcomes.
Sir, it's a wonderful talk. Sir, I wanted to ask you that in PCOS trial, I was intrigued to know that what was the pregnancy outcome after that weight loss?
Yeah,
Do you have any?
I don't think we have data on that. We don't have data about the pregnancy outcome, but it is expected when metformin, which is a very, very humble drug, which does not lead to a very huge reduction in the body weight, when metformin is used in PCOS, it increases the fertility rate, right? So there is no reason why a drug like this, which will lead to a huge reduction in the body weight and all the other parameters of PCOS, I'm sure that is going to increase fertility, but we need data on that.
Thank you, sir, for your clinical tips. And I remember the tip just now you have given about 2 minutes counseling before writing this. You have given the same few years back when SGLT2 was launched.
Right.
It also requires a 2 minutes counseling.
Absolutely.
Right. Thank you, sir. Thank you once again.
Thank you very much, sir, for the excellent and thought-provoking session. Your valuable insights have certainly enriched our learning and will benefit all of us in clinical practice.
Let us begin our next scientific proceedings with a topic that has transformed the way we monitor glycemic control and personalized diabetes management. To enlighten us on the practical advantages and limitations of blood glucose monitoring and continuous glucose monitoring, it is our privilege to invite Dr. Rajesh Kesi, sir. Sir, may I request you to kindly deliver your lecture?
Before I hand over the dais to Dr. Keshri, I would like to thank him as chairman of Bihar chapter RSSDI on behalf of all the members of Bihar for taking out time and traveling over here. Thank you, sir.
Thank you so much for the invitation. First of all, thank you so much for the wonderful hospitality that I'm experiencing yesterday and since the moment I landed. So thank you very much. One thing I just wanted to note here that Bihar chapter of RSSDI is perhaps one of the most academically active chapters that I am seeing. So a big round to Bihar RSSDI. Now, over to my talk. I think it's a very interesting talk. So here, the topic given to me was SMBG versus CGM. So I think I would like to go through the salient points which I personally felt are important for all of us to know. What are the comparative differences between these two modalities? First of all, we understand both of them are for monitoring glucose in our patient. So I am quite sure that this is nothing new. You all would be aware of this. This Maruti 800 has been companion for years and years and years. And this car can still be seen, I think maybe in some places. It was very sturdy and very useful, and I have spent my, I would say, adulthood with this car. And now you have this advanced Mercedes, full of technology, loaded with technology, and obviously it gives you a better experience of ride, better safety. And perhaps if the roads are good as they are now, you can reach your destination much faster than in a Maruti 800. So, in ways, it is something like this, the glucometer. It is dependable, it is reliable, and it helps you when nothing else helps you. It will guide you in managing therapy treatment everywhere. But moving ahead of the glucometer, we have now the CGM continuous glucose monitoring systems. Many companies are now making and marketing systems which have become much affordable now after the last decade, since the last decade. So what is the big difference? So both of them measure glucose, and even the core method, the biochemistry method by which the glucose is measured is same in both. But the medium from which the glucose is measured is different. So when we do a finger prick test, what we measure is the glucose level in the mixed arterial blood, because it has mixture of both artery and arterioles, which are very superficial and venous. And but what we measure with the help of CGM is something different. CGM measures the glucose level in the interstitial fluid. Now there can be difference between the measurements of glucometer and CGM. In fact, I did an experiment and I presented that in last year's ATDD also. While comparing glucometers, we compared two glucometers. We did tests in laboratory and we used two sensors on one individual, and did a glucose challenge test and measured the differences in these small times, like we were testing glucose levels with all these different modalities every 10-15 minutes. So what happens is when there's a steep increase, a spike of glucose, that can be immediately measured with the glucometer. but that may give some lag time to show up in the CGM readings. So while if the readings are stable, that is a long period during the fasting or after meals, after more than 2 hours after meal, the readings may be absolutely similar, but otherwise there can be a difference of reading during the time of acute changes in the glucose levels. Ease of use. Now glucometers are painful. Every prick is painful, so the patient thinks number of times before pricking himself or herself. Whereas if you put a CGM sensor, the CGM sensor also experiences a prick, but that prick is so minor that my patients who have needle phobia, who cannot give blood and who cannot check sugar levels also, when they were applied with the sensors, the modern sensors, they never felt. I didn't tell them that there's going to be a needle going inside. They didn't even feel it, so it is virtually painless, even though it has a small needle which is going inside to place the filament. So the study by our own Dr. Jyoti Dev, which shows that 60% of people with diabetes report pain and inconvenience. And in reality, the SMEG, which should be done 2 to 3 times a day in type 2 diabetic patients, is hardly done 3 to 4 times a week. I would say that 3 to 4 times a week is also too much. Majority of the patients even do not do that despite our advice. So the duration which can be associated with these two monitoring modalities. So you see, one prick gives only one value at that point of time. But in CGM, you have the advantage that you get information, and now you get real-time information on your phone for 5 to 15 days depending on the sensor that you are using. The Libre Freestyle 2 that we are using now has a working life of 15 days, and ever since sensor may be available in coming months in India, which may last for 6 months or even 1 year. The 6-month one is already being used. So glucometer gives you a snapshot, and the CGM sensor provides a movie, a real movie that you see on the TV or in the cinema halls of the current picture, and how the glucose levels are behaving, when they rise, when they decrease, when they stabilize. One of the most important things that I think have come up with the era of CGM devices is the newer metrics which we have available now to monitor and to treat our patients and to modify their therapy. With glucometer, we have only one metric, that is the glucose level, which is measured. Even though there can be some estimation of glucose if you take glucose readings 9 times a day, and there can be an estimated A1C, because that's how the average glucose value of HbA1c was calibrated and calculated. But if you use CGM, and most of the approved CGMs, they give you many other metrics which are now becoming standard of care, moving on ahead from HbA1c and static glucose values. One is the ambulatory glucose profile. That is very important. We'll come to it in the next time. Time in range, time below range, time above range. And a very important thing is the arrows. If any of you have seen your patients using the glucometer, the CGMs, So the CGM, when the reading is taken, shows the trend arrow, whether your glucose level is stable, whether it is going up, whether it is going down. So a patient, when uses a CGM and a monitor for that, would immediately understand whether the patient is going to stabilize now, or the sugar is shooting up, or the sugar is shooting down. So measures can be taken about that. Not only that, these CGM, they provide real-time alarms as well. So the patient, even though may not feel, but the patient would be alarmed by the CGM sensor through his phone that the sugar is going to become low, or the sugar is already very low, or the sugar is very high. So these alarm can be given, whereas such things obviously are not there with glucometer, even if you measure them for over a long period of time. And it is connected care with the help of CGMs. The patients are connected directly to the doctors. Most of us doctors would have dashboards, and to their relatives, to their caregivers. Now this is the ambulatory glucose profile, which I'm sure you all must have seen many times. So this gives you a snapshot of your patient's glucose profile. The thick line in the middle is the median, and you can see above and below the 25th and 75th percentiles, and wider was the 10th and the 90th percentile. Now we have time in range. This is the percentage of time that the patient or the person monitored is in these specific ranges. So the target range is, you can set that yourself also, but it is usually taken as 70 to 180 and should be greater than 70%, and below 70 should be less than 4%. Below 54, that is the very dark red one at the lower end of this bar, should be less than 1% of the time, and the patient should not be more than 180 for more than 25% of the time, and above 250 only for less than 5. I'm just putting up this across to convey the idea that, you know, we have newer metrics with which to monitor the therapy, and we have now the recommendations of international societies, in fact our own RSSDI as well, on what are the right, what is the right time in range, or what are the right newer metrics in different scenarios, in type 1, in type 2 diabetes, in pregnancy in type 1 diabetes, or in gestational type 2 diabetes also. So this is a lot, this makes our work a lot easier, I would say, and would definitely improves the outcomes. The TIR, time in range, is can also corroborate the outcomes and the complications of diabetes in our patient individually. As here we can see that for each 10% less time in range, retinopathy progression increased by 64% and microalbuminuria outcome by 40%. The same as that we saw for HbA1c. Decreased time in range is associated with increased long-term complications independent of A1c. So this is again about the new metric which we can have only from the CGM and not from glucose monitoring. Hypoglycemia is one thing that we all understand that we should as much as possible avoid hypoglycemia, but the glucometer can give you only one single value at a time, and that too if the patient measures while the patient is undergoing hypoglycemia. But if you have a sensor on the patient, you can see retrospectively and understand when the patient was going into hypos, and this is especially important for patients who have hypoglycemia unawareness. So this is an actual patient, but it is not recent. It is quite an old patient. I just want you to have a look at the CGM reading that we have. You see, she is having hypoglycemia throughout the night. This is not because of the depression of the sensor, because after I saw these reports, I asked her to measure. She measured, and she was having hypoglycemia. Otherwise, in this elderly lady with 27 years of diabetes, HbA1c 6.7 is not bad, right? But when you look at the CGM reading, you understand the level of hypoglycemia that she's having every day, and this is one of the reasons of her problem. Glycemic variability is just as important, because we all understand that glycemic variability is associated with adverse cardiovascular outcomes and adverse otherwise outcomes also in diabetes. So CGM helps in finding out the glycemic variability in the patient, whereas to find the same thing you would need at least 12 to 13 pricks to be done daily over a long period of time, which may not be feasible with all. Now these are all my patients, These are real patients with HbA1cs between 7 to 8%. You can see the difference of the graphs, and they are from 8.2 to 8.6%. Again, you can see the different graphs, the different trends in the AGP. So I would say that, you know, just as we are all different, we have different faces, different ages, it's like a crowd. Every face, every human being has their own glucose profile, and that glucose profile can be identified only with CGM. So CGM per se has therapeutic advantage. It can be used for monitoring therapy, for making changes in insulin and oral medications, and over a short period of time you can reach very good results. Now this is again my patient, and you can see what we started and what we've achieved in just 6 days. But there are obviously limitations to both the modalities, so we should have a very good understanding when to use what and when to avoid and not rely on what. So in glucometer there is a challenge with patients with needle phobia. The cost is usually affordable, but it does not provide any continuous data. It is useful in ICUs because that is one modality which we usually use to monitor patients. And the user burden is significant because no one wants to prick their fingers. It is painful. I'll take just one more minute. So the advantage of CGM is that it is painless. There's no pain, there's no visibility of the needle, so even if the patient is afraid of needles, he or she doesn't understand that there's a needle going inside and readily accepts it. The problem with CGM is the cost. It is still very high. Even now also you cannot buy a CGM for less than 3,500. That is the cheapest one available from anywhere. There's also a lag time we have to understand in the readings, like I was showing in first or second slide, that when the dynamic changes in the glucose level, whether it is rising or whether it is going down, at that time there would be a lag in the readings in the CGM, whereas in the glucometer you can have immediate results. And this CGM is not very useful and reliable in ICUs because it takes a time, and because of the IV infusions and medications that are given, the results may not be that reliable. Another issue, a challenge that is there with CGM is that most of the sensors and their filaments have a 24 hours melting time. They have 1 hour melting time, but the reliable results come only after 24 hours of usage. So cannot be used in those conditions for at least 1 day when the sensor is already there. So I think I have covered the most important points which I thought we should all know and should be aware of the differences between the CGM and the glucometer. CGM can motivate patients to achieve better targets and improve quality of life, newer goals which lead to newer efforts. It is the reports are practical, they are discernible, you can monitor day-to-day changes. They are preferred by patients over HbA1c, and use of CGM itself decreases HbA1c. This is a therapeutic modality. There are many studies I haven't put up for the want of time, which have shown that the patients who are consistently on CGM sensors, that leads to significant reduction in their HbA1c values, not only in type 1 diabetic patients, but in type 2 diabetic patients and GDM and gestational diabetes patients as well. So glucometer provides a snapshot. It may miss the highs and the low, and limited data for decision making requires frequent finger pricks and less insight into patterns and trends. I think we have covered most of the options, so thank you so much.
Thank you, Dr. Rajesh, for excellent talk. And everyone knows that there is some pro and cons of this glucometer or SMBG and the CGM. Now the CGM is increasing in day-to-day practice, and even in tertiary town, district headquarter practitioners are using this CGM also. So any question from the audience, if you want to ask any question regarding CGM and SMBG? I think Dr. Rajesh has covered all the aspect of the SMBG and CGM, and thank you very much.
Thank you.
Thank you very much.
Thank you, sir, for the insightful and informative presentation. Your discussion has provided valuable clarity regarding the appropriate role of BGM and CGM in modern diabetes care.
We now move on to a fascinating and rapidly evolving area of diabetology. It is my privilege to welcome Dr. Santosh Kumar sir for his talk on monogenic diabetes beyond type 1 and type 2.
Santosh Kumar Singh needs no introduction. He is one of the most academic person, I think, in our batch or even in the Patna. And you all know that the monogenic diabetes is underdiagnosed, and there are many cases of monogenic diabetes which is been there in the in clinical practice, but most of them are underdiagnosed, or and it needs a very high index of suspicion to diagnose this monogenic diabetes mellitus. So over to Dr. Santosh Kumar Singh regarding monogenic diabetes.
Honorable chairpersons, respected seniors, friends. Yeah. So once again, honorable chairpersons, respected seniors, dear friends, I was told that some sessions have gone off, so I have the liberty of extending my time with the permission of the chair. There was a scarcity of reciprocation from the audiences, and it goes the reverse way when I give a talk. So be prepared. How many MDPGs are here? ऊपर उठाओ ठीक से चलो. So my sincere thanks to RSSDI team and Dr. Jitendra, Dr. Mrityunjay for giving me this opportunity to visit this nice place, first time for me, and with them to BK to facilitate my darshan to Tala Chandi and today at Mundeswari temple. So once again, thanks BK. BK has yesterday said that almost all the talks are 80% AI, 20% of the original talk. In my case, I can assure you it is just the reverse. And it's almost more than a decade of foolishness, which you can say has led to this 80-20 ratio. So we start with this, atypical diabetes, and you can see the spectrum. And it starts with insulin resistance, the monogenic forms, and when we talk of monogenic diabetes, it comes in our mind that it is linked with insulin secretory dysfunction. But we need to know that it is not only insulin secretory dysfunction. We can have insulin resistance syndromes, we can have the syndromic conditions, we can have pancreatogenic diabetes which can be monogenic. So we need to be versed with all those things in today's talk on precision medicine. And this is the spectrum. You see insulin secretion aspect and insulin sensitivity across the spectrum. You see lower down the typical MODY and the neonatal diabetes linked with insulin secretion, and the upper part you see the insulin resistance syndrome, the lipodystrophies, and you can easily guess about the insulin resistance aspect in these cases. I won't go into LADA and the KPD, ketosis prone atypical diabetes. And these are the entities of monogenic diabetes. And I emphasize again, on the top you see a mention of neonatal diabetes, monogenic diabetes, syndromic forms, I told you, mitochondrial diabetes, and everybody remembers the term MIDD, mitochondrial inherited diabetes and deafness. And this is one of my case, PAX8 mutation. You won't see in the routine spectrum of the list which you have. And this case having type 2 diabetes along with hypothyroid. Father was having hypothyroidism, father was diabetic, and this proband of mine, she had this impaired glucose. I would say it was in the diabetic range, normal fasting, and she had thyroid dysfunction. And that led to this test which I asked for, and PAX8, everybody can correlate with the thyroid pathology. And it is responsible for development of the thyroid, so you can have dysgenetic or absence of thyroid in these cases. But the role of PAX8 on the pancreas is again very distinct. It is responsible for the immune and consequent inflammatory aspect where we can impact the glycemia. And interestingly, one of the families which I was going through which had this mutation, they were typically having gestational dysthyroidism and gestational diabetes. Okay, and type 2, as I said, this was in one of my father of the proband. Continuing with the monogenic diabetes, lipodystrophic forms, and you know the generalized ones, the acquired ones, and this is again important. If you see the list, methyleptin is there in the generalized one and even in the acquired type as you have in the AIDS, and you see the requirement of insulin. If you are not going for other therapies, they may require very high dosage of insulin because of the insulin resistance part. Now, lower down, we come to the severe insulin resistance category. And as I said, it is not only insulin secretion. We have this insulin resistance aspect, the different disease conditions, Donahue syndrome, Rason-Mendenhall, type A insulin resistance syndrome, and look at the drugs. And we know about the insulin sensitizers. Metformin is not typically an insulin sensitizer. It works to some extent on that way. TJDs, we can well say, if you talk of one insulin sensitizer, we talk of TJD. And if you talk of one intrinsic insulin sensitizer, anybody's guess from the PGs? The most potent intrinsic insulin sensitizer, because I have a slide on that, so you have to be versed with that. Any guess? चलो हिंट देते हैं, leptin. Most potent insulin sensitizer. अभी भी नहीं है, leptin की बात आएगी तो adiponectin की बात आएगी. Okay, so remember, it's most intrinsic insulin sensitizer. Okay. Now this is Donahue-Rason-Hall type A insulin resistance syndrome, and here there is a role of GLP-1 receptor antagonists, and we all know they facilitate insulin secretion, they facilitate insulin sensitivity, so by that way we can easily guess their utility. Lower down, you see the pancreatic diabetes. So this is again, we have genetic syndromes, monogenic forms, which can lead to this pancreatic diabetes. This is the monogenic forms of diabetes, insulin resistance, mutations in the IR genes I talked about, type A insulin resistance, leptosonism, Rason-Mendenhall. You have the lipoatrophic diabetes, and you have mutations in the PPAR gamma. And look at the treatment part. PPARG, low-fat diet is required, physical activity is required for FTO gene mutation, and these are monogenic forms of linked with insulin resistance. Here, on the top, you find a mention of adiponectin more than 7 nanogram per liter, it is a microgram per ml, and anybody can guess what it is. In insulin resistance, more than 7, less than 5. So I would just give you, more than 7 is suggestive of insulin resistance. Now can anybody just correlate this? If you are having a patient with adiponectin more than 7 microgram per ml or nanogram per liter, it is suggestive of severe insulin resistance syndrome. Okay, and this is adiponectin paradox. What happens is, in these cases, we expect a lower adiponectin, but what happens is, it's a bit different from the routine obesity which is linked with low adiponectin. In routine obesity, we have hypertrophic adipocytes, and they are hypoxic, they release, and they are responsible for the apoptotic, less of adiponectin secretion. Okay, they elaborate the cytokines, TNF-alpha, IL-6, which suppress adiponectin. But in insulin resistance syndrome, the adipocytes are okay. Okay, so primarily it is the release is normal. And one thing which is very interesting is insulin as such suppresses adiponectin. So in insulin resistance, there is lack of that suppression and there is relatively increased adiponectin. So this value of more than 7 is suggestive. We are not routinely doing adiponectin, but you need to keep this in mind, and particularly from the mechanistic aspect, I like this slide. This is about PPR gamma gene. The pro aspect is responsible for 25% of the cases, but this is more in the Caucasians, less in Asians. You have reverse data at V. Mohan Center with PPR gamma. This is again a case of insulin resistance, and you can see the IRS1. And this patient with a BMI of 38 requiring L-thyroxine to the tune of 125 microgram per day, and he was having hyperuricemia. This is again a clinical context. Insulin resistance is linked with hyperinsulinemia, and low uric acid you can easily correlate with low insulin secretion. Okay, so this is a very clinical aspect you need to remember. This patient, I will give a talk when I will talk about the GLP-1 receptor agonist and the dual agonist, why this case is interesting. But presently, this is just to highlight that this is one of my cases of the monogenic forms of insulin resistance diabetic. This was the pancreatic type I was talking about, the SPINKY gene mutation, 34-year-old male, requiring MSI. It's very tough to get these patients in adequate control. Sometimes they have hypos, particularly in the morning time, and some patients of mine, they are on twice daily boluses. They don't require the basal insulin, but what I was trying to show about this SPINKY gene mutation, these patients, they do have more of exocrine and endocrine dysfunction. They are younger, but the pain is less. So this is the difference between SPINKY mutation and non-SPINKY mutation type 3C. Okay, these patients who are harboring it, they are younger, having more of exo and endocrine dysfunction, but less of pancreatic pain. Another case of mine, again, this girl, 15-year-old, and in this case, I made a diagnosis of atypical diabetes. You saw my first slide. There's by Bala and Stone, they have this RADIANT group, the rare and atypical diabetes data analysis, and I put this patient at diagnosis as atypical diabetes. And then I went for the genetic makeup, and the mother of this female patient, she had CKD, she had hypothyroidism, and she died at a very early age. And when I inquired, maybe a leading one, they said that in the end she was having pancreatic issues too. So this patient having PRSS1 gene mutation and SELA2A, PRSS1 is linked with the pancreatitis part. SELA2A has distinctively been linked with the increased thrombogenesis. So it is having its cardiovascular aspect too. And I have mentioned the term diagenic. So we are talking about monogenic. This patient is having diagenic when you are having two gene abnormalities, and we do see even MODY patients typically having these diagenic forms, even insulin-resistant monogenic forms having sharing two things. So they can be diagenic, they can be oligogenic. Okay, and there are ample data from India of MODY being diagenic. This is the approach part. This is course, family history, physical examination, diagnostic tools. But the message I want to give is this. The suspicion, as BK said, you need to be suspicious about this entity. So high likelihood of rare and atypical diabetes, like in the previous case, I made this diagnosis. Treatment prepubertal or non-obese, Mendelian pattern with early onset, syndromic ones, and Ajay Boss might have talked on this aspect of lean PCOS or GDM, and you have to lean PCOS, GDM. So remember this aspect. You should think of a rare and atypical diabetes network. And you see the bottom line, a decade on average with incorrect diagnosis. And as I said, it was my foolishness, and I was one of them to diagnose a case properly after a decade of seeing the patient. Okay? So this is another one, the monogenic diabetes. If you talk of two papers, I give the first one, Stone and Bala, on that atypical one, and this is typically monogenic diabetes by the Zhao's group, again in the same year, it was 2024, 2025, and this is in brief, 3.1 to 4.2% cases of the monogenic forms neonatal, MODY, and syndromic forms. And interesting, you see the two overlaps. 4.5% adolescents diagnosed with type 2 were MODY. 6% of children with type 1 diagnosis were again MODY. So amongst these also, we do see this amount. If you see at the percentage, approximately you'll see that 5% data regarding MODY. This is important, and you should learn it by heart, the pages. Okay? This was the Jhao's paper. A total of 165 patients were identified as having suspected monogenic diabetes. And I told you the diabetic monogenic was neonatal, MODY, and the syndromic forms they have included. They have not included mitochondrial one. Characterized by the absence of beta cell antibodies. So it is important to rule out anti-GAD. And meeting at least one of the following. So ek se hi ho jayega. Okay, diagnosis of diabetes or hyperglycemia before 12 months of age, and we talked about the neonatal part. We have to screen it over there. And then positive family history of non-autoimmune diabetes mellitus or hyperglycemia in one or more generations of first-degree relatives. Now, when I talk of this generational transmission, always remember that in today's scenario, with the high prevalence of type 2, we do see patients having 3-generation histories. Okay? But one thing which should catch your mind is one-sided transmission from maternal grandmother, mother to the child, okay, or paternal grandfather, father and the child. If you have like that, you should be suspicious about this MODY 3-generational transmission, okay. So diagnosis before 12 months, positive family history. Then I come to the stable mild fasting hyperglycemia. Anybody can say which condition I am talking about. If you are seeing a stable mild fasting hyperglycemia, it's there. You saw the patient 1 year ago and he has come again with the same similar fasting. Any condition. Only fasting, MODY. Which one? Type 2. Glucokinase deficiency. You don't require any treatment for this routinely except in GDM. And this last part was presence of extrapancreatic features. Okay, so stable hyperglycemia, extrapancreatic features, this is very important. And two are investigative. One is the C-peptide, and the basal one, and the stimulated one, 0.2 to 0.6, and this is in nanomoles per liter. So for nanogram per ml, you have to multiply into 3. For over 3 years after the onset. Okay, and the next part is the monogenic insulin resistance. So you have fasting insulin more than 20, with a peak insulin post OGTT is 150. And severe insulin resistant is fasting of 70. So not remember the OGTT one, remember the fasting category. Okay, 20 and 70 as insulin resistant and severe insulin resistant. This was from Jhao's group, and you can see the percentage. MODY 67%, NDM 16%, and syndromic forms were 17%. Okay, this was in his paper, and here GCK was 37%. We have variation in the reportings of different authors. This is what I emphasize, monogenic diabetes syndromes recommendations. All children diagnosed with diabetes in the first 6 months of life should have genetic testing for neonatal diabetes. Children and adults diagnosed in early adulthood who have diabetes not characteristic of type 1 or type 2 that occurs in successive generations should have genetic testing for MODY. You have MODY calculated for that purpose, but why I always, what I emphasize is the de novo mutation. You don't get any family history. You have this patient with de novo mutation. So that index of suspicion is very important. Okay, and this is MODY, which we are talking about insulin secretion, right? And a bit of a theory. Neonatal diabetes, first described by Kitzel in 1852, classically defined as diabetes mellitus occurring in the first 6 weeks of life. Some suggest a cutoff of 6 months. That's why that screening of 6 months for in all cases of neonatal diabetes. Single gene disorders rather than classical autoimmune type 1 diabetes. So this is going in favor. Look at the incidence part. This is not the prevalence. This is the incidence, 1 in 3 to 4 lakh live births, and how to differentiate transient from permanent. Okay, and the cutoff is 1 year. Based on the grounds of resolution or persistence beyond the first year of life, you term this as transient or permanent neonatal diabetes. And these are the genes acting at different places. So you can just go through later. Why it is important, and again, very important over here. An accurate diagnosis is essential for accurate diabetes treatment plan, definitely. Insulin for type 1. Sulfonylurea may be used in occasional cases with HNF1 MODY. Additional advantages, accurate additional testing, like testing for other autoimmune conditions like thyroid conditions, celiac disease, which we should do in type 1. It's not required if you have diagnosed as HNF1 alpha MODY, just for example. Next is again important, accurate information on recurrence risk, the heritability part. And for type 1, it is 1 to 6%. Definitely type 2, it is much higher, 20 to 80%. Autosomal dominant antibodies, yes, 50%. So this is important. Now it matters to our patients, why did I get diabetes? Okay, maybe patients, occasionally they do ask this question, and you will be in a better place to answer this. नीचे GADA और celiac disease की है, कोई बता सकता है पीछे से या आगे से भी? GADA, AITD and IA2 is celiac disease. This is just the association. If you are having a patient with GAD positive, they are more likely to have concomitant autoimmune thyroid disease. If it is IA2, that is fogarin or tyrosine phosphatase, they are more commonly going to have celiac disease. So there is this. So paradigm shift, early neonatal diabetes, across the spectrum you have all the list. I won't go into the details of it, and definitely the treatment varies. In occasional patients you can treat with sulfonylurea, majority of them they require insulin. Okay, GCK, no treatment except in GDM. This is again, I won't bore you with this, MODY 2 and gravidity. Okay, माँ को है, बेटा को, बच्चे को नहीं है, दोनों को है, and what will be the manifestation? This is very interesting. कभी बड़े talk में बताएंगे. So this is the algorithm MODY, and what we are interested is the lower part. Okay, so the abrupt onset, non-obese insulin deficiency, अगर positive antibody है जो कि हमने उस slide में बताया था, you need to rule out GAD which persists for a longer time. If it is no, you again should think of MODY and you go for the genetic testing. But what is again important clinically is the non-genetic biomarkers, and one of them is HSCRP. MicroRNA we are not doing, but HSCRP we can do. Okay, so possible MODY from these two things, and the typical type 2 obese insulin resistant, definitely they also have negative autoantibodies. So normal weight, non-obese, index of suspicion, generational transmission, one-sided more commonly. So this is the HSCRP, more than 0.75 milligram per liter, and most of the reports which you see, it is less than 1. So having a negative predictive value of 99.7%. Just imagine, MODY 3. Okay, less than 0.55 is sequencing first, and if it is, this favors MODY 3. If it is more than 0.55, you think of other MODYs. Above 0.75, it negates MODY. It's just almost 100%. This is the message today, and as I said, my foolishness. Make and review your own diagnosis. कोई दूसरे ने पुर्जा पर भेजा है type 1, type 2. Always look by your own. Make your diagnosis, and always be ready to change even what you have diagnosed. So this is making and reviewing our own diagnosis. My way of workup, hyperosmolar symptoms suggestive of insulin deficiency, family history, the generational aspect, acanthosis nigricans, BMI suggestive of insulin resistance, the body weight part, ketones and C-peptide, again a measure of insulin secretion, anti-GAD antibodies type 1, ultrasound abdomen, pancreatogenic, and other extra pancreatic issues which the patient can have, and lastly, the genetic analysis. So this is what I follow in my clinical practice. One of my patients, 2012, 14-year-old, body weight and weight age, height age is there. For children, you have to give this. Random blood glucose 573, HbA1c 13, presence of hyperosmolar symptoms. So definitely suggestive of insulin deficiency. Family history was not significant. Patient was put on insulin. Okay, and that went on. Workup, hyperosmolar symptoms present. Family history, nothing significant. Acanthosis BMI was 25, acanthosis absent. No insulin resistance ke parameters nahi the. Ketones, urine, blood, negative on insulin. Okay, you need to remember this. If a patient is already insulin, you cannot rely much on the ketones. And the C-peptide, you see, again in the mid-range, anti-GAD was negative. Ultrasound findings, renal calculi was there. And later on, in the initial ultrasound, nothing was mentioned. Later on, I found there was a report of agenesis of dorsal pancreas. Okay, so dorsal ventral pancreas, you have different populations of the cells which you have. Okay, so from here, any guess what we are seeing? Hyperosmosis were present, family history nahi hai, acanthosis nahi hai, BMI 25, C-peptide well maintained, anti-GAD negative. So with that agenesis, कुछ तो गड़बड़ लगी रहा है. So we definitely should keep this in mind. This is not a typical, तो कम से कम rare variant में तो डाल ही देंगे इसको. And then searching it. PDX1, here again you have permanent neonatal diabetes, pancreatic agenesis. Okay, and the next one is HNF1 beta, beta cell, and here you have the typical RCAD, renal cyst and agenesis and diabetes. So this is the term we use for RCAD for HN1 beta. Okay. So for diagnosis of MODY, which we used to practice, and we remember 3-generation penetrance, less than 25 years of age, and OHA responsiveness initially it was for 5 years and then it was for 2 years, but this is clinical, fine. What I told you about the de novo mutations and deletions, okay, this can happen, so index of suspicion is very important. And these are the scoring system which have been positioned. So you see the left and right kidney separately, they have shown hyperechogenicity, renal cysts. Lower down you have low serum magnesium, the early onset gout is there, pancreas में hypoplasia hai, genital tract abnormalities, and the liver abnormalities can also be there. So all liver abnormalities, हम लोग सिर्फ NASH पे नहीं जाएं. You should think of these entities in this category of patients. नीचे लिखा हुआ है MRKH syndrome. कोई गाने से भी है या सब MD वाले हैं? MRKH, any guess? चलो मायर रोकिटेंस्की के बताओ. Keister and H is Hauser syndrome, the absence of the uterus which you have. So this can be a presentation of HNF1 beta. Okay, just remember it. So in this case, the genetic analysis score more than 8 is suggestive of HNF1 beta. This was put forth by Fager. Pancreatitis agenesis 4 point, liver dysfunction 2, hypomagnesemia 2, early onset gout 2. So 8 तो यहीं पे हम लोगों का था, and then the diagnosis part. MODY 5, confirmation, genetic analysis 3, Fager score helped. Now MODY overview, neonatal diabetes की बात बताया था, Kitzel 1952. This is MODY, discovered 1974 by Robert Tattersall. 1996 में terminology of MODY came into being. Percentage जो बता रहे थे, आमतौर पे 5% का figure दिखेगा आप लोगों को. It is characterized by diagnosis at a young age. Okay, 10 to 30 years of age, even as early as 2 to 3 years. So it is not that typical peripubertal time. Absence of islet antibodies, and we need to know that 2 to 4% of type 1 may also have absence of autoantibodies. Okay, and autosomal dominant inheritance of a single gene mutation, and that I emphasize on the paternal maternal aspect, but always remember de novo mutation. Okay, so MODY 3, and this is just to emphasize the presentation age. So we talked about this proband 21-year-old, maternal grandmother 9, mother 16. तो ये हमेशा नहीं होता. दादी पहले पता चला नानी को, उसके बाद माँ को, 9, 16 और 21 में पेशेंट का. Another case, है ना, mother 32, maternal grandmother 50 years. Okay, so it is not always there, and 17 years for the proband. Okay, so this is a varying age. This patient was treated with liraglutide. This is interesting again. Genetic variability. In a recent study from Korea, the MODY was found in 21%. The diagnostic rate was similar to that in UK. But what is different, you see, in the latter study in UK, molecular genetic testing, GCK, was responsible for 50% of the cases. Okay? And it was only 1% in the Chinese study. And this corroborated with the Japanese study. Okay? So 1% GCK MODY, 9% was HNF1 alpha. As I said, different authors have different percentages of this one. So it is not always GCK which is having the maximum prevalence. And this entity again, the studies from Korea, Japan, China suggest that East Asia has a high prevalence of a not yet identified form of diabetes, that is MODY X. Okay, and you may be the one who will be responsible for finding another MODY. Okay, so that index of suspicion is important be proactive in diagnosing these conditions. And today we have this facility of having the genetic test. I don't know whether your center is having that facility or not. Do you all have? No? अभी तक नहीं. जितेंद्र जी से रिक्वेस्ट रहेगा कुछ कराइए इन लोगों का. चलिए, treatment aspect, I won't go into the details. Typically it is sulfonylurea insulin, but we do have other agents now. SGLT2 inhibitors, और जल्दी जल्दी slide बढ़ाते जाएंगे. My chairpersons might be restless. Magnesium पे change है, glycosuria पे है, and important is MODY3, they have low threshold for renal glycosuria. Despite that, DEPA has been shown to increase glycosuria in MODY3. Look at the values versus type 2. 20 versus 10 millimoles even in type 3. So these molecules do work even in that condition. So this is about that. Nephrolithiasis may SGLT2 inhibitors. I was talking about my case of nephrolithiasis. So this can again be helpful in that. Recent evidence of SGLT2, you can see the advantage on glycemic control, lowering of body weight in appropriate patients, and you have the benefit on the kidney and the cardiovascular system. So I won't now, I come to this MODY, GLP-1 and gliptins. This is the pathway, and this is important. The patients responding with sitagliptin, and the interesting study is Glimlina study, gliptin, 5 milligram linagliptin, glimepiride with a lower dose, and the advantage was lesser hypoglycemia with this regimen and improvement in glycemic variability, standard deviation, coefficient of variation. So this is the Glimlina study in patients with MODY3. GLP-1, बहुत नहीं detail में जाएंगे. This mechanism is important. Upregulation of PAX6, which is responsible for differentiation of pancreatic islet cells, reversal of abnormal glucose metabolism. It protects against beta cell apoptosis. Okay, and definitely we all know its impact on ameliorating insulin resistance. So all these aspects favor the use of GLP-1 receptor agonists, but occasionally even in these patients we get benefit with addition of a small dose of sulfonylurea. And this is there in our clinical practice. Sometimes we use these molecules and then the addition of a sulfonylurea helps. Addition of pyruvate helps in overall management. Okay? And the HNF1 beta patients, they do have disproportionate insulin resistance, and there is a different role of pyruvate in patients with those conditions. So I think I have come to the end, and my request to all, make and review your own diagnosis. This is my protocol for the diagnosis. This you need to remember by heart, and a high level of index of suspicion. This is the generational aspect, the non-obese, early onset, biomarkers, HSCRP, don't forget, and thank you all for the patient hearing.
Excellent presentation, Dr. Santosh Kumar Singh. One thing I want to ask regarding this, the basic message from the Dr. Santosh Kumar Singh on this topic is monogenic diabetes is not uncommon. If the patient is less than 25 years of age, if the patient is negative and lean, and there is a 3-generation history of diabetes, you must think of other form of diabetes like monogenic diabetes mellitus. Dr. Santosh, you have presented very well, and what is in your clinical practice, how many cases of MODY you have seen in your practice, and what percentage of GCK, particularly MODY 2, you have found in your clinical practice?
Not a single GCK. My patient category almost very minuscule. I have patients with HNF1 beta, which I said it took a decade to diagnose. HNF4 alpha I do have. HNF1 alpha I have. Insulin resistance I showed you, that is not MODY, insulin receptor 1. And I have UCP3 mutation, another part, again linked with insulin resistance to some extent. So this is, and still I would say, despite this, we do hesitate in going for rampant genetic testing. Okay, so you even with that suspicion, you cannot write it blindly. So we do have that limitation still.
No,
And I will share you one thing. I was asking Dr. Jitendra to have a genetic lab. One of my patients, this HNF1 beta, I asked for a genetic test at AIMS Patna. And the genetic report came as 46XY. Just imagine. So this is the status in that sort of institute. I'm not anything against AIMS. Many friends are there over there. But this awareness is very important. And this proactiveness from that administrative side also, the testing for these things.
One thing in your slide, one of the 36.7% of the patient is having the MODY 2, the G6 MODY.
No, as I told you, it was from the Jhaul study and the UK study. One of the Chinese studies showed only 1%.
In our practice, in the beam ones have demonstrated that 125 cases of the MODY. Out of this, the MODY 3 was the commonest, and the G6 MODY 2 was the less common in that. But in other Caucasian population in this Sweden, they have series. They have documented the series of the patient, and they have calculated that the 2 to 4% of the patient, particularly in the pregnant women, having harboring this MODY 2. True. So with this word, do you want to have any question from the audience regarding the MODY 2? And I request our chairperson, Dr. Saibal Guha, to have a specific topic, a special session for this monogenic diabetes mellitus to highlight the different aspect. And Santosh Kumar Singh very clearly said that if you are suspecting the monogenic, it is not the deficiency of insulin, this parenteral mode not important. Even the insulin resistant having the monogenic form of diabetes. So thank you very much, Santosh Kumar Singh, for excellent and delivered some presentation. Thanks a lot.
Thank you, Dr. Santosh Kumar sir, for that excellent, insightful session on monogenic diabetes. Your expertise has helped us appreciate the importance of precision diagnosis and individualized management in diabetes care.
We now move to the interactive segment of the session. The floor is open for question and discussion.
As there are no further questions, we come to end of stimulating academic session. On behalf of organizing committee and all delegates present here, we extend our sincere gratitude to our esteemed speakers for sharing their knowledge, experience and valuable insights.
We also express our heartfelt thanks to our respected chairpersons, Dr. B.K. Singh sir, Dr. Saibal Guha sir, for their guidance, thoughtful moderation throughout the session.
The discussions this morning have truly reflected the spirit of session theme from practice to precision and have provided us valuable take-home messages for our day-to-day clinical practice.
Thank you everyone for your enthusiastic participation and attention.
Now we request Dr. Ajay Kumar sir to come on dais. Now I request Dr. B.K. Singh sir to felicitate Dr. Ajay Kumar sir. Now I request Dr. Rajesh Kesri sir to come on dais. Now I request Dr. Saibal Guha sir to felicitate Dr. Rajesh Kesri sir. Now I request Dr. Santosh Kumar sir to come on dais. Now I request Dr. BK Singh sir to felicitate Dr. Santosh Kumar sir. Now I request Dr. Jitendra Kumar sir and Dr. R.K. Singh sir to felicitate our chairpersons. Now I request Dr. Jitendra Kumar sir to felicitate Dr. B.K. Singh sir. Now I request Dr. R.K. Singh sir to felicitate Dr. Shaibal Guha sir. Thank you so much, and now we will proceed to the next session.
Thank you and have a wonderful day ahead.
Distinguished faculty, esteemed delegates and guests, a very warm welcome to session 9 of RSSDI Bihar Conference Midterm 2026. We titled this session Diabetes Care Beyond Basics, and that phrase carries real weight. Because today we move beyond glycemic targets and HbA1c threshold and into the broader, often underexplored terrain of diabetes and its systemic intersections.
Absolutely. Diabetes is no longer a disease of glucose alone. It is a condition that touches every organ, every age group, and every dimension of a patient's life. The presentations in this session are curated to reflect precisely that philosophy, advancing patient-centered diabetes care by bridging evidence with everyday clinical practice.
We are privileged to have the distinguished speakers who will share their expertise across the spectrum of topics that challenge us to look beyond conventional management. May I now invite chairperson for this session, Dr. Jitendra sir and Dr. Ranjan sir. May please take your seats, sir. With your permission, let's begin this session, sir.
Now, we warmly welcome Dr. Adnan Imam to address us on the topic of sarcopenia and aging diabetes that is increasingly relevant in aging population and one that is often overshadowed in the diabetes clinic, the silent co-traveler of sarcopenia. Please, sir.
Thank you. First of all, thank you, the Bihar RSSDI chapter, for giving me this opportunity to speak on a problem that is very much common in our OPDs. Every patient, I'll say not every, but most of the patients, they will say, sir, I'm losing weight. Even after sometimes controlling proper measurements with controlling diabetes with proper measurements, but still we are not able to sometimes address the problem to the patient. So what can be done? What can be assessed, we will go through all in the coming slides. So sarcopenia and the aging diabetic, we'll be talking about this. When we call it as sarcopenia, sorry, when there is progressive and generalized skeletal muscle disorder which is actually characterized by the loss of muscle mass, the muscle strength is reduced, and decline in the physical performance of the patient because of the above two mentioned things. So when we see how it evaluated, it started from 1989, which was first described, and then 2010, and then 2018, where European group said that it becomes one of the primary parameters to look about it. And the current review tells that sarcopenia is not just a sarcopenia thing, it is a muscle failure syndrome which is reducing the quality of life of the patient. So when we are treating diabetes, we are not treating only numbers right now. We have a lot of things associated with respect to the metabolic factors of the patient, including the loss of muscle mass. And we think that it's a small problem, but it is not. The global burden in elderly population is approximately ranging from 10 to 27%, and with diabetes it is approximately going up to 35%. And people who are getting more elderly day by day, like above 80 years, they are approximately having 50% problem because of this sarcopenia. And the Indian perspective with respect to the burden of sarcopenia is we have a rapidly aging population and a growing diabetic population with it. So both of these two will create more problem for the quality of life of the patient. So how it is, what it is, why it is actually. So the pathogenesis, the sarcopenia in elderly patients with type 2 diabetes will have like hyperglycemia, one of the part, then age, advanced glycation products, the insulin resistance, the oxidative stress that body is handling, and inflammation, and all these factors, they contribute to type 2 diabetes and sarcopenia. So the risk factor, this slide I think because of no issues. The risk factors when we talk about, we have the intrinsic factors as well as the extrinsic factors. So the extrinsic factors I will tell is because they are more modifiable sometimes. So the physical inactivity, they increases the risk of sarcopenia. The sedentary lifestyle, we all know, they increases the risk of sarcopenia. Obesity itself is a factor which have sarcopenia issues, and other factors including some acute or chronic illnesses as well. Then the intrinsic factors will have muscle degradation, the hormonal disorders, and the mitochondrial damage and chronic inflammation. So the risk factors associated between sarcopenia and diabetes, other than the what I have gone in the previous slides, is the age as well, because the aging will increase sarcopenia. Smoking is one of the factors which contributes to sarcopenia. Vitamin D deficiency in many studies have been associated with loss of muscle mass sometimes if ignored. Then hormones including testosterone, then physical inactivity and energy intake. If not a proper calorie intake is taken with respect to the protein, carbs and all. See, first of all, carbs should not, we don't say that like empty carbs, don't give carbs, it's not like that. We have to give carbs as well, but the protein intake is very much low with respect to the data we have in Indian population. So why diabetes is one of the risk factors? Because there is hyperglycemia, insulin resistance, there is more inflammation, there is more mitochondrial dysfunction, and which finally indirectly or directly gives to muscle loss. So when we see about the many mechanisms including aging and diabetes, and then the diabetes itself. So all these factors will have directly or indirectly the oxidative stress damage, the mitochondrial dysfunction, which causes cell damage, and these finally gives a result for the reduced muscle mass, reduced strength, and reduced function and reduced quality of life. And this in a whole will cause sarcopenia. So actually I was planning to put this slide at the last, but it came in between, no issues. So when we talk about sarcopenia, we sometimes treat the patient with drugs, and treatment part I will also take care of, and I think I will come back to this slide at last as well. So what are the adverse outcomes which is associated with sarcopenia in diabetic patients? Why we want to prevent sarcopenia? Why we are talking about sarcopenia actually? We are talking and we are addressing this subject, we are addressing this topic because Because of that, patients have physical frailty, they have a risk of falls and they have a risk of fractures, which can not, sometimes if we say falls and fractures doesn't matter a lot sometimes, but if a femur gets fractured, it's okay, a disability will be there, but any head injury will lead the very poor quality of life of the patient. Depression, then cognitive dysfunctions, hypoglycemia itself may be one of the associated symptoms because of low appetite and body weight, and vascular complications linked to higher risk of retinopathy, nephropathy, and economic burden as well, because more hospital visits will be there, more sometimes multi drug prescriptions will be advised to the patients. So the clinical consequence on the patients will be they have falls, fractures, frailty, on and off hospitalization, which will increase the economic burden to the patient, loss of independence, their quality of life is decreased, and then mortality may have more. So when we think that we are dealing with sarcopenia, then we have to find it, we have to assess it, then we have to confirm it, and we have to see the severity. There's a SARC-F questionnaire. I'll tell what questions are there in that, and then if it's positive, we have to assess the muscle strength, the grip strength, the chair stand test. All these tests can be done on OPD basis, and then if we suspect the sarcopenia, then there we have to confirm sometimes with the muscle mass, the MRI, the DEXA, the bioelectrical impedance analysis also. Then we confirm sarcopenia, and then we see with the severity of the muscle function, the pace, the tug, and all. So we say that it is a like severe sarcopenia or not. So the diagnostic criteria as per the European work group, they says that stepwise approach of low muscle strength is probable sarcopenia, low muscle quality and quantity confirmed sarcopenia, and this causes the poor physical performance of the patient, reducing the quality of life of the patient, causing severe sarcopenia. Why I am saying severe decrease in quality of life most of the time is because we can correct the things and we can improve the quality of life of the patient. When the patients comes to us, they have a hope that they will now have low weakness, they can move and they can do their daily life which they are not able to do previously. So the tools that I have talked about was SARC-F questionnaire, which have 5 components of strength, assistance walking, rise from chair, climbing stairs and falls. A score of 4 is approximately suggestive of sarcopenia. And the muscle strength assessment, when hand grip test, a dynamometer is actually sometimes used. For the cutoff for men is 27 kgs and women is 16 kgs, whether how long they can press and hold the dynamometer. So the chair stand test is one of the easiest which you can do in the OPD. That you can ask the patient to sit on a chair without the hand arms in the chair. The patient should ask to cross his arms along his shoulders, and the patient should stand and then sit and then stand and sit for 5 times as fast as possible, and that time should be less than 15 seconds. So it is one of the very common tests that you can do to assess in your OPD basis. Now when we talk about the muscle mass, the gold standard is MRI and the CT scan, and the practical methods that is approachable and less costly will be a DEXA and bioelectrical impedance analysis. So the parameters of perpendicular skeletal muscle mass will be seen. When we talk about, we can assess also by the performance of the muscle by physical performance assessment, the gait speed that is less than 0.8 meter per second, the short physical performance battery, timed up and go test, and 400 meter walk test. This will assess the quality and quantity of the muscle mass that is there. So these are the things. The most common thing that will be easy to do on your OPD basis is the chair test. When we talk about the comprehensive treatment strategy of sarcopenia in elderly patients, as I have told you, the pathogenesis is related to the hyperglycemia, the oxidative stress, the insulin resistance as well, the inflammation and the advanced glycation end products. So the treatment first of all comes with a sufficient protein and energy intake with good amount of essential amino acids, the recommended amount of essential amino acids, vitamin D and calcium supplementation sometimes, because vitamin D deficiency, as I told you, is related to sarcopenia in various studies, and some supplementations which are okay, some data suggest about them and some data not, is about omega-3 fatty acids. But the main cornerstone of the sarcopenia is exercise with strength training. and the anti-diabetic drugs. I'll go back to that slide of antibiotic drugs. Now, when you talk about the effect of drug therapy on muscles, the effect of sarcopenia with respect to therapies, that the drugs we are using for the patients, when we see about biguanides, it is in some data it is positive, in some data because it's negative, but in insulin secretagogues, they have a very negative effect on sarcopenia. Glucosidase inhibitors, we right now no data is like exactly no sufficient data is there. Thiazolidinediones, it is a positive, but it should be used carefully because of the retention. And DPP4 inhibitors, they have a neutral and a positive effect. GLP-1 and sodium glucose transporters, GLP-1 they have a positive if the patient is not doing strength exercise. GLP-1 is right now making a lot of sound in our daily to daily practice, that it has been given for the weight loss to the obese patient with diabetes, and without diabetes, as per the recommendations from the international guidelines. I'll not go deep into that. What about the BMI NL 2730? But GLP-1 is making a lot of noise in today's market. But in the trials also, and in the clinical practice as well, it has been seen clearly that a proper strength exercise should be inoculated with the treatment plan if possible, and a protein intake should be increased, so that the sarcopenia effect should be seen less when it is compared with the patients who are not taking protein and who are not doing strength exercise. And the SGLT2 receptor inhibitors, they have some studies have a positive effect, but some may have not shown any plus or minus signs with respect to sarcopenia. So, and insulin, they have surely a more positive effect. I would not say unclear, but a more positive effect. So, management, I told you, exercise, nutrition and optimization of diabetes therapy. Resistance training is very important, at least 2 to 3 sessions a week, which will increase your muscle mass, which will increase your strength, which have help you in overcoming your insulin resistance, and all of these will help you reduce in frailty, falls, less fractures because of that. And the quality of life will surely be improving than the patient if somehow have depression because of that. He or she may come out of the depression as well because of the good quality of life. Now, when we talk about protein requirement, how much protein and all, we always tell to the patients, take protein, how much protein we have to increase. Like if we talk about older patients, protein of 1 to 1.2 gram per kg per day, and in sarcopenic individuals we can increase it to 1.2 to 1.5 grams per kg per day of meal. Additional nutrients, if needed or if indicated, like vitamin D, essential amino acids, omega-3 fatty acids and leucines, should be added to their diet with respect to natural food or food supplements if needed. And diabetes therapy considerations will be that I have already talked, is to preserve the muscle mass and to avoid excessive weight loss. Sometimes the drug itself may be causing it, sometimes, most of the time, the diabetes is causing it. So we have to monitor the nutritional status, we have to monitor the muscle strength, the functional capacity, especially in elderly receiving intensive weight loss therapy. So why we are talking about this is because many of the patients who are losing their weight, who are losing their mass, they are saying that I'm getting lean day by day, I'm not able to do my work, I'm not able to concentrate on my work. Sometimes because of that, now they are not going to parks, they are feeling sometimes dull, they are feeling sometimes ashamed that people tell them that they are getting very, very, very weak. So if we address this problem of the patient, and the patient is starting his own or her own daily lives properly with respect to whatever needs he or she have, the problem will be solved, and the patient will be really overwhelming, and we will giving a good gift to the patient, especially with respect to our advice. So to summarize the whole thing is, sarcopenia is a highly prevalent in aging diabetic patients, we all know, and it accelerates muscle loss through multiple mechanisms that I have already discussed. And the sarcopenia actually worsens the glycemic controls too, because sometimes the patient is not eating and all. And early screening should be routine in older patients with diabetes. Resistance exercise is must with adequate protein intake. These two are the most These two are the most important cornerstone therapies of the sarcopenia management, and multidisciplinary management improves outcome. So sometimes we have to revise the drugs as well, and revision of the drugs also helps in improving sarcopenia part. Thank you for your attention.
And how it can be managed, and we have also discussed the importance of exercise and good nutrition and importance of good hyperglycemic control, and this is definitely going to help in clinical practice to all of us, especially postgraduate students. Thank you for your nice presentation. Any questions from the audience?
Thank you, sir. The interplay between muscle loss, insulin resistance, and functional decline in the elderly is a sobering reminder that diabetes care must be holistic and age-aware.
Our next presentation brings to a light a topic that sits at the intersection of endocrinology, cardiology, and patient dignity, often discussed in hushed tones, yet critical to comprehensive diabetic assessment. We invite Dr. Angad sir to present erectile dysfunction as a cardiovascular marker.
Good morning, everyone. To all August audience, respected teachers, seniors, office bearers of RSSDI. At first, I would like to make a slight change. My topic is actually secondary causes of diabetes. Not taking too much time into context setting. When we talk about diabetes mellitus, with diabetes, what our common perception is that it's type 2 diabetes mellitus. And it's true also because most of the cases of diabetes mellitus, about 90% is type 2 diabetes mellitus. Type 1 account for about 3%, and rest of the diabetes are other secondary causes of diabetes mellitus. It could be some endocrinopathy, it could be pancreatic malignancy, it could be genetic mutations such as related to MODY, it could be because of cystic fibrosis related problems. So our job is to find a needle from haystack, and why this is important. Is it only because for some academic gratification, or is there really any meaning of doing all such exercises? Idea is that for secondary diabetes, if we are able to find the cause, in many cases we can even reverse the diabetes mellitus, we can change the course of the diabetes mellitus and disease, and in many cases we can find life-threatening conditions such as we can find pancreatic malignancy. If the patient is suffering from cystic fibrosis, we have to work up much more, and in many cases we can switch from insulin to OHA such as for MODY, and some like mild hyperglycemia such as glucokinase MODY we don't have to treat altogether. Now this will be the outline of the flow. First will be the recognition and diagnostic clues. Second, pancreatic disease and endocrinopathy. Third, drug-induced and genetic causes, and what are the evidence-based management strategies. Now, as we have discussed, secondary diabetes represent about 10% of all cases and demands management distinct from type 2 diabetes mellitus, because underlying conditions may be life-threatening such as pancreatic cancer, pheochromocytoma, and treating the primary cause often improves or reverses glycemic control. Management algorithm differs substantially from a standard type 2 diabetes management protocol. Now, what are the red flags? not all cases of diabetes mellitus we have to rush for all the investigations, because it would not be cost effective. It will create unnecessary apprehension in the mind of the people. So there are certain red flag signs in which we have to look for secondary diabetes. First is lean type 2 diabetes mellitus. If any patient of diabetes is not obese and negative for autoantibody, then we have to think of secondary diabetes. If it is rapid onset with initiation of any high risk drug, such as we can talk about steroid, we can talk about tacrolimus, we can think of any common antipsychotic agent. Apart from that, patient is having some stigmata of endocrine features, such as for Cushing's patient is obese, stria is there, proximal myopathy is there with pheochromocytoma. If patient is having some phew-like spells, then we can think of endocrine causes also. And for pancreatitis, we have some history, either history of recurrent pancreatitis, any surgery in and around pancreas, or patient having symptom of chronic malabsorption. In any patient age more than 50, and if there is new onset diabetes mellitus with weight loss, we have to think of secondary diabetes. And if the patient is having family history, then we have to think of secondary diabetes. Now, pathophysiological mechanism guide therapeutic target. If the patient is having insulin resistance, we have to start on insulin sensitizers. If the patient is having impaired secretion, it's secretory defect, we have to use either insulin or insulin secretagogues. Beta cell restriction, then we have to go for insulin therapy. And if the patient is having combined mechanism, then we have to individualize multi-target approach. Now, to diagnose secondary diabetes, we have to take a tier approach. What is the beauty of this tier approach? First, it will not miss any cases. Apart from that, it will not increase the cost of therapy. So in tier 1 test, we do C-peptide, autoantibody in all cases of secondary diabetes mellitus. Tier 2 is more targeted. Depending upon the clinical features, we can look for cortisol, IGF-1, catecholamines. And in tier 3, it's advanced testing, where we do pancreatic imaging, genetic testing when indicated. Now, laboratory pattern can distinguish between secondary form of diabetes from primary diabetes. For type 3 C diabetes, that is pancreatic diabetes, there will be evidence of pancreatic exocrine insufficiency, and we can measure it by measurement of fecal elastic, that will be less than 200 microgram per gram. For endocrinopathy, as we have discussed, that particular hormone will be elevated. For example, if we talk about acromegaly, there will be elevated IGF-1. For Cushing's, cortisol will be there. Thyrotoxicosis, TFT we can see. And drug induced, there will be temporal relationship of starting any drug. Now coming to the pancreatic imaging, it identifies a structural abnormality defining type 3C diabetes. For chronic pancreatitis, we might see calcification, ductal dilatation, and pancreas atrophy on either CT or MRI. Pancreatic cancer, mass lesion will be there with ductal obstruction, and post-surgical history will be there. Again, the plain CCT abdomen will not solve our purpose. We have to ask our radiologist for pancreatic protocol, CT or MRI. Now, because as we talk, pancreatic disease have highest chances of development of secondary diabetes. Pancreatic cancer have about 85% chances, chronic pancreatitis 65%, cystic fibrosis related disease, diabetes in about 55% of cases, and post pancreatectomy it can go up to 90%. Now, as we know, if the patient is having pancreatitis and chronic pancreatic atrophy, they have very high chances of development of hypoglycemia. Reason is that the both mechanism defense towards hypoglycemia, whether it's insulin or glucagon, both are abated. So in those patients, the diabetes is very brittle, and we have to adjust multiple basal bolus regimen in those individuals. As we have discussed, insulin is the gold standard. Basal bolus regimen, it mimics physiological secretion. Hypoglycemia education is a sine qua non, And metformin can be given in selected cases where mild pancreatic defect is there. And for exocrine, for this pancreatic diabetes, enzyme replacement is necessary. Now, when we are talking new onset diabetes after age 50 with symptoms, we have to think of pancreatic neoplasm, and we don't have to delay pancreatic imaging pending the metabolic control. Coming to the endocrinopathies, Cushing syndrome causes diabetes in about 30 to 60% of the patient through cortisol-driven insulin resistance. Clinical features I will not repeat. Glucose pattern is postprandial and afternoon peaks. Primary treatment address hypercortisolism. And for glycemic management, we can go for metformin, insulin required for high dose or persistent steroid exposure. Acromegaly and pheochromocytoma both causes reversible diabetes when the tumor is addressed. And in acromegaly, about 20 to 40% of patients develop diabetes mellitus. For pheochromocytoma, in both conditions, tumor-directed therapy is the primary intervention, and anti-diabetic agents are the bridging therapy. Now, coming to drug-induced and genetic causes. Glucocorticoids acquired are the usual culprit. Risk factors are doses, higher doses, longer duration, older age, elevated baseline BMI, and family history of diabetes. Glucose pattern is postprandial and afternoon peak. And prevention strategy is use the lowest effective dose, consider steroid sparing alternative where clinically appropriate. Now, how to manage steroid-induced diabetes? For those patients who are taking morning prednisolone, we have to cover afternoon glucose peak. For that, we can give either morning NPH or morning basal therapy with provision of prandial insulin. For multiple daily dosage, we have to go for basal bolus regimen. If the we are planning to increase the dose of steroid, proportional insulin up titration should be done, and during steroid tapering, aggressive insulin reduction should be done to reduce the risk of rebound hypoglycemia. Now coming to the other molecule, antipsychotics. Depending upon the agent, risks vary. The highest risk is with olanzapine and clozapine, moderate risk with risperidone and quetiapine, and lowest risk with epiprazole and ziprasidone. So before starting any antipsychotic agent, baseline weight, glucose, lipids should be measured and then measured periodically. Again, postprandial diabetes affects about 10 to 40% of solid organ recipient within the first years. Tacrolimus has highest beta cell toxicity, so those patients in whom the risk of developing diabetes is very high, we can consider substitution to cyclosporine. Now coming to monogenic diabetes, because why this genetic analysis is required. Many of the MODIs such as HNF4 alpha and HNF1 alpha, for them sulfonylurea in low dose is very highly effective, and we can stop the insulin altogether, and it's even superior to metformin. For glucokinase MODI, it doesn't require any treatment in normal individual. During pregnancy, we have to treat GCK MODI. And genetic testing should be ordered in those individuals who are of young onset, a strong family history, atypical features, or suspected MODI in all three generations. Now one more entity, that is lipodystrophy syndromes, which causes very extreme insulin resistance, and for that we sometimes need insulin in doses of 100 to 1000. And for that now we have a molecule also available, metrelleptin, that is a leptin receptor agonist, which is the cornerstone of treatment alongside high dose insulin and metformin. Now coming to the evidence-based management strategy. Effective management of secondary diabetes requires matching therapy to the underlying mechanism and always addressing the primary cause first. Treating the underlying condition is the primary intervention. For surgical, tumor resection should be done for pheochromocytoma, pituitary adenoma, and medication adjustments should be done for steroid, and for immunosuppression, as we have discussed, we can reduce or change the immunosuppressant. Now those individuals who are having insulin deficiency, predominantly in secondary diabetes, they will require insulin therapy. Indications are type 3C diabetes, post-pancreatectomy, cystic fibrosis related diabetes, and preferred regimen is always basal bolus. Now those patients who are having insulin resistance more, for them metformin is the first line of therapy. Apart from that, we can give SGLT2 inhibitors, GLP-1 receptor agonist, and insulin in escalation doses. Now, how to screen for complication of diabetes in secondary diabetes? Dictum is same, whether it's primary diabetes or secondary diabetes, we have to screen for microvascular as well as macrovascular complication as recommended by the ADM. A special population required tailored management beyond the standard protocols. For hospitalized patients, basal bolus insulin should be given and not the sliding scale. Pregnancy optimized preconception glycemic control, insulin is preferred. Most oral anti-diabetic agents are contraindicated in pregnancy. And for transplant recipients, close NODAT monitoring with early intervention, minimize diabetogenic immunosuppression doses from the outset only. Coming to the take-home message, the first thing is suspect secondary diabetes. In those individuals who are diagnosed as lean type 2 diabetes, rapid medication onset hyperglycemia, or systemic features, always look for secondary diabetes. In type 3, that is pancreatic diabetes, insulin is the gold standard. And always in secondary diabetes, treat the cause that may reverse the diabetes mellitus. For steroid, match the insulin dose to steroid pharmacokinetics. And any new onset diabetes after age 50 years, we have to go for urgent imaging to rule out the possibility of pancreatic neoplasm. That was all from my side. You all have been wonderful listener. Thank you all.
Thank you, Dr. Angad, for explaining about different causes of secondary diabetes and in which patients we should take care of and where to suspect secondary diabetes. We have nicely discussed preventable and treatable cause of secondary diabetes, and you have explained these things in very simplified manner. Thank you for this. Any questions from audience?
Thank you, sir, for your presentation. Your message will be carried by our delegates to their clinical practice.
So, and for our next presentation, we address one of the most pressing complications in long-standing diabetes. As our therapeutic armamentarium expands, the question is no longer whether to protect the kidney, but how far beyond the conventional can we go. We request Dr. Harshvardhan sir to present diabetic kidney disease management beyond ACE inhibitors and ARBs.
Good morning to all of you, and I would like to thank the organizers for giving me this opportunity to present this diabetic kidney disease management beyond ACE inhibitors and ARBs. So the objective of my talk would be to discuss the recent advances, evidence of renal protection, discuss the 4 pillars of therapy, and recognize the efficacy and safety considerations of multi-targeted therapy. If we look at the epidemiology of diabetic kidney disease, so diabetes, as we all know, is a growing global burden, and nearly 30 to 40% of diabetics have renal involvement, and proportion of end-stage renal disease attributable to diabetes ranges from 12 to 55% in different cities. So diabetic kidney disease is a medical catastrophe of worldwide dimension. If we look at the pathophysiology of diabetic kidney disease, it has got multiple targets like metabolic dysregulation, inflammation, hemodynamic perturbations, and a lot of new pathological things are coming up. The therapeutic targets and new treatment options in diabetic kidney disease hovers around SGLT2 inhibitors, GLP-1, where you target oxidative stress, you target metabolic factors, you target inflammatory pathways, fibrotic signal, and many hemodynamic mechanisms. And we have come a long way. Way back in 90s, the era of ACE inhibitors to the era of flozins. And gradually things are, improving day by day. If we see the current holistic care strategies of management of diabetic kidney disease, it's lifestyle modification. You have first-line diabetic drug therapy. You have additional risk-based approach. So the classical 4 pillars, as we all know, starts with RAS inhibition. And it all started with this 2 landmark trials which was published in the same year 2001. One was the renal trial and other was IDNT trial, which did suggest that ACE inhibitors and ARB have, they causes around 50 to 20% relative reduction in endpoints. And the annual GFR decline dipped from around 8 to 10 to 4 to 5 ml per minute. So this was very significant. That was the first indication that ACE inhibitors ARB had a role in prevention of, progression of diabetic kidney disease. So if we see ACE inhibitors in ARBs, I just want to stress upon the point that usually the commonly used ACE inhibitors ARBs are currently which we use are the telmisartan, and ACE inhibitors which we normally use are the ramipril. And the maximum tolerable dose in patients with kidney renal dysfunction is ramipril around 20 milligram and telmisartan it's 40 milligram. And if we see the antihypertensive potency of ACE inhibitors in ARBs, so the most potent ARB in terms of antihypertensive efficacy is azilsartan, and the minimum potency is of losartan. So how long to use? This has been debatable, that how long to use and when to use. So currently there is no creatinine suggesting that you should not be using ACE inhibitors or ARBs. You can use ARBs with any creatinine value and you can continue it for long. In fact, the STOP ACE trial was one of the major trials which did suggest that in fact stopping RAS inhibitors had a worse outcome. So one should continue, and this was a subgroup analysis which, as you can see, that even if GFR falls below 15, one should continue using ACE inhibitors in ARBs if you are able to monitor potassium. So rise in creatinine and potassium are the major factors which we all have to look at. So once you initiate ACE inhibitors in ARBs, monitor potassium every 2 to 4 weeks, and you have to see potassium levels and GFR decline. So normally if GFR decline is more than 30%, think of other cause. One of the important causes bilateral renal artery stenosis, and think of other causes as well. So always, whenever you have a rise in creatinine with ACE inhibitors, just don't attribute it to be a cause of rising creatinine. You need to stop NSAIDs. You need to stop other nephrotoxic drugs. You need to see whether the patient is dehydrated or not. So you have to be very cautious in stopping these drugs. So SGLT2 inhibitors is the another pillar, and we all know that it causes natriuresis, causes glycosuria, and the major benefit, the most widely accepted mechanism of renal protection associated with SGLT2 inhibition in patients with CKD is you have reduction in hyperfiltration, that is single nephron glomerular filtration rate. So this is one of the major mechanism by which it prevents the progression of kidney disease. We all know the major trials, CREDENCE, DAPA-CKD, EMPA-CKD. We all know the evidence, current evidence of using SGLT2 inhibitors. The current recommendation of our guidelines is that you should use it SGLT2 inhibitors till GFR is 20, or you can continue using it until the patient, if the patient doesn't tolerate it, or kidney replacement therapy is initiated. So if you see, it reduces CKD progression by around 40% regardless of chronic kidney disease etiology. So currently, SGLT2 inhibitors should be a part of standard of care to minimize the risk of kidney failure in chronic kidney disease patient, even with non-diabetic CKD as well. And SGLT2 inhibition has got some protective role when you use it with other drugs as well. So it reduces apart from its renal protective mechanism, it also has a favorable, response to hyponatremia as well as hyperkalemia. So you can continue using it SGLT2 inhibitors with RAS blockers. But despite RAS blockade and SGLT2 inhibition, patients with type 2 diabetes and advanced kidney disease are still, they have a very high risk of progression. This has been seen with almost all the trials. And residual albinuria at around 6 months was associated with worse kidney and cardiovascular outcome. And even the ADA had a suggestion that, you know, reduction in around 30% or greater albinuria is recommended to slow chronic kidney disease progression. So if we go further, the third pillar which we commonly use now is non-steroidal MRAs, which is Findrinone, which we commonly now using it in patients with chronic kidney disease, diabetic chronic kidney disease. So major cause of inflammation and fibrosis is mineralocorticoid receptor overactivations, and there are multiple mechanisms which leads to MR overactivation in CKD with type 2D patients with diabetes. And MR overactivation and associated mechanisms are unaddressed and not a primary target of present therapies like RAS inhibitors and SGLT2. So with the classical aldosterone antagonist, the Findrinone has some protection as far as the sexual side effects are concerned, and it has got a shorter half-life, and it has got no major metabolites and tissue distribution, so lower rates of hyperkalemia and manageable, which is manageable by treatment interruption. So the major trials which looked into the protective mechanism of Findrinone was the Fidelio DKD, which was a primary kidney outcome trial, and Figaro DKD, which was a primary cardiovascular endpoint. And you can see it has got a substantial reduction in CKD progression. And the fidelity was a pre-specified pool analysis of both the trials, and which did suggest that Findrinone on the standard of top of care reduces the risk of clinically meaningful cardiovascular and kidney outcomes in patients with diabetes. But one should should see that the patient, to have the maximum benefit of Findrinone, should be on the maximum tolerable dose of ACE inhibitors or ARBs or SGLT2 inhibitors. So this was the basic requirement of these trials. One of the trials which we are doing currently is the chronic kidney disease adaptive platform trial in investigating various agents for therapeutic effect, which is Captivate trial. And we are recruiting patients and following them up for patients with, non-diabetic chronic kidney disease to see whether the efficacy of Findrinone in that subgroup of population. It is a parallel phase 3 placebo-controlled parallel group adaptive trial. And recently, around few days back, the FIND CKD study is also out in JAMA, which gives an evidence that Findrinone is even effective in the glomerular diseases causing chronic kidney disease. That is a FIND CKD study which has just come up. So currently, where as a nephrologist we are using it. So currently we are using it with anyone who's got a GFR of more than 25 with a normal serum potassium level. So we can use it in anyone with a GFR of more than 25 with a normal serum potassium level and albinuria more than 30 milligram per gram, despite maximum tolerable dose of RAS inhibitors and ARBs. And again, as you can see, if you continue using it, SGLT2 inhibitors with Findrinone, it has got some favorable response in terms of hyperkalemia. So when SGLT2 inhibitors, it also helps to continuation of MRAs, and dapagliflozin, this was a trial which was published in JASN, and it did suggest that dapagliflozin in combination with eprinone reduced albinuria to greater extent than the either drug alone compared to eprinone. Now the fourth pillar is, of course, GLP-1, and GLP-1, as we all know, is an incretin hormone produced in distal bowel and colon that triggers the release of insulin in response to oral glucose intake. So GLP-1 receptor agonists are efficacious in reducing the risk of a cardiovascular events in patients with type 2 DM. And if you see the cardiorenal protective role of GLP-1, it has got many direct and indirect effect. The basic direct effect is it is endothelial protective, so other causes are secondary to it. So multiple mechanism, it is both renal as well as cardiac protective. So this was a flow trial which looked into the patients of type 2 DM with chronic kidney disease. It has got around good proportion of patients with diabetic patients with chronic kidney disease, and as you can see, the semaglutide had a favorable outcome in terms of albuminuria and other renal outcome. So GLP-1 receptor antagonist improves albuminuria and GFR in patients with type 2 DM, and as you can see in all those trials which had a substantial patients with chronic kidney disease like SUSTAIN 6 and LEADER, the semaglutide has got a favorable outcome. So this was a recent meta-analysis which was published in Lancet, which did suggest that GLP-1 has got a favorable renal as well as cardiovascular outcome, and you should continue adding it to your three pillars. So the current recommendation is that you should use, in patients with chronic kidney disease, use GLP-1 with proven cardiovascular or kidney benefits for people with type 2 DM and CKD who are at high risk of major adverse cardiovascular or kidney events and who have not achieved individual glycemic target. This is 1A indication. So this is the most recent KDIGO diabetic kidney disease guidelines. And use GLP-1 based therapy to people with type 2 DM and chronic kidney disease who have not met individual HbA1c targets. The choice of GLP based therapy should prioritize agents with documented cardiovascular and kidney benefits, and to minimize GI side effects, start with low dose and titrate up slowly. Now comes the combination therapy. So we have individually discussed all these therapies. Now let's see how the combination therapy works. So, theoretically, as you can see, every pillar has got different mechanism of action. And so SGLT2 inhibitor basically reduces glomerular hyperfiltration, reduces major cardiovascular events driven primarily by heart failure and certain cardiac death, and modern reduction in blood pressures. Non-steroidal MRAs have more prominent effects on inflammation and fibrosis, most pronounced on heart failure and outcomes, and neutral effects on blood glucose. GLP-1 addresses the underlying metabolic abnormalities, reduces myocardial infarction and stroke, and there is substantial reduction in glycated hemoglobin and body weight. And interestingly, in the credence, the major hospitalization occurred early, that within first 12 months. So the combination therapy now should be the ideal treatment approach. So the traditional approach was that you start with one drug and subsequently you added on the other drugs. Now then came the rapid sequence approach. Now we follow what we call as accelerated risk-based approach. You see the KDIGO heat map, stratify your patient in the risk category, and hit hard as early as possible to have the maximum benefit. So combination therapy has a role. So this was a confidence trial which boosted the confidence of nephrologists that combining SGLT2 inhibitors with finerenone did had a favorable outcome in UACR and renal outcomes. So this was a meta-analysis which did suggest that combination therapy is beneficial. So to summarize, diabetic kidney disease ideally should be dealt with a comprehensive care strategy. You should target at both the levels of system, provider and the patient. As far as system is concerned, access to healthcare, affordable healthcare, attends for healthcare and adequate infrastructure and training. As from the provider perspective, prescribe appropriate protective agents and follow-up, appropriate knowledge of data, make diagnosis, undertake appropriate tests. From patient perspective, fill scripts, adhere to therapy, attend ongoing medical care, continue therapy. Thank you.
Thank you, Dr. Harshvardhan. You have explained very nicely, and you discussed different methods of how to prevent or delay development of kidney disease in patient of diabetes. One important thing you said, as you said, that we can use ARB irrespective of level of creatinine or irrespective of GFR, provided we have to go for periodic checkup of potassium. Just I want to know how frequently you want to check for potassium.
Ideally, the recommendation is 2 weeks.
Every 2 weeks we have to check for potassium.
At least monthly we should do it.
Okay, thank you. Any questions from the audience?
enlightening. You talked about using Ramipril 20 milligram, which we hardly usually use that. And I think there can be risks of hyperkalemia with such high doses. So do you use in your practice 20
So normally
milligram?
nephrologists, we do use it in glomerular disease. We go up to 20 milligram.
And it is well tolerated without side effects, cough
As again
and
I
all
said,
that.
you have to monitor potassium, and if you're able to monitor potassium, and if it is less than 5.5, you can keep on using it.
So do you frequently see the cough side effect, throat irritation, because when we reach the 10 milligram dose, I see that increases quite substantially.
So normally for nephrologist, ARBs are the usually preferred drugs. We normally use ARBs more frequently than ACE inhibitors.
Thank you.
Wonderful as usual. Only two things. The fourth pillar in non-diabetics, it's endothelial receptor antagonist. So GLP-1 goes over there. So, and the second thing, recent paper on non-proteinuric DKD. And interestingly, all these drugs, which were classically meant for patients with albuminuria, they all have been positioned in the management. So maybe because of the evidence they have, but no specific data was given, which these drugs having how much benefit on the progression of eGFR. They are just opined that all these ARBs and the four pillars, whatever are there, you can use it in non-DKD. Maybe we are not having anything before us. Emphasis was on the tubular aspect in the non-proteinuric one, and they have they have asked for the inflammatory drugs like pentoxifylline and all. So your take on that, the non-proteinuric DKD?
So in fact, if you see the basic change in paradigm shift in understanding the pathophysiology of diabetic kidney disease, from the onset, we have been taught that diabetic is glomerulocentric. So that has to change now. So it is no more glomerulocentric. So more and more mechanism is coming up where now the shift is from glomerulocentric to the tubular interstitial compartment. So initially we were focusing on proteinuria. We are still doing that. But when we came up with large amount of data from non-proteinuric diabetic kidney disease population, we saw that in fact they had a worse decline in GFR. They had a very worse decline in GFR. So if you compare proteinuric diabetic kidney disease versus non-proteinuric diabetic kidney disease, non-proteinuric are worse. So because of the multiple mechanisms involved, and this is the beauty that this fourth pillars, since they are targeting multiple pathways, so now it is very interesting to look that what they are going to do with the non-proteinuric diabetic kidney disease. And with in fact, the interim data which we have on around 50 patients in the Captivate trial, you'll be surprised to know that in fact Findrinone are doing wonders in patients with non-proteinuric diabetic kidney disease.
Lesser and lesser CV events in the non-proteinuric type, any mechanistic?
Sir, non-proteinuric, retinopathy is less, definitely less.
And CV events also?
CV events, maybe, you can say that, but still, the data is not...
It's in the paper.
There's the paper, sir, but large number of data is still awaited, sir, because we have to see the current outcome.
Harsh, excellent presentation. One thing regarding that, the endothelial dysfunction is common in all the vasculopathy or even in the kidney disease. Do you have any ongoing trial on microRNA and non-coding RNA regarding the treatment of this?
Pardon, sir, I didn't get you, sir.
The microRNA treatment or the non-coding RNA treatment or any ongoing trial is in this regarding?
So there are a lot of trials which are going on with microRNAs and this, but the data is still not out, sir.
Any questions? More questions from?
Can I ask any question? One question from Angad? Yes. Angad, you have nicely explained this secondary diabetes. one question, what you suggest a patient of MODY 2, missed glucokinase MODY, in a pregnant woman, what she should do in pregnancy, or what you suggest a patient of MODY 2 with pregnancy?
We have to start on pregnancy, start on insulin therapy, and genetic analysis should be done. Because if it is mutation can be, we need genetic, but fetal might get autosomal dominant or recessive depending upon that. Fetal outcome can also be affected. So we need that fetal assessment of mutation also, sir. Yes. First thing is good glycemic control, sir, for pregnancy. And apart from that, we have to tell fetal genetic analysis should also be done.
In the initial part, you have to control glycemia. And I showed you the chart on the maternal and the fetal GCK deficiency. If the fetus is not affected, okay, you have to treat. Okay, if the fetus is affected with the same, you don't require any treatment. The basic thing is from the nutrient delivery, you will have insulin secretion that will produce macrosomia in the child. If the if the fetus is also harboring the same mutation, you don't require any treatment for that, because there won't be any insulin kinetics over there. So it's a bit tricky going for amniocentesis and that. Now they are coming up with the cell-free DNA, which will make things easier, but it's still in the infantile stage.
Hello. Actually, I come across that the very clinical point is that particularly the patient is having GSK, MODY, in the mother. We don't know whether the child, the fetus is suffering from this mutation or not. The basic clinical point, if the genetic testing is not available, then you have to just measure the abdominal girth. If there is no macrosomia, patient is not harboring the this GCK modification. Is abnormal, you need a treatment. That is a practical point. I don't know whether this is valid or not.
So just for discussion, point of discussion, when we talk of the practical point, once the macrosomia is already there, the damage is already done. So I think the right advice for all of us should be to give good glycemic control. And even if insulin is required for that, I think it should be given, because once the macrosomia is already developed, that means that there is some degree of hypoglycemia.
If the fetus is not harboring this GCK modification, if you give insulin, the fetus develop the hyperinsulinemia and leading to the complication of the patient. That is a very tricky part of that particular insulin. So you have to assess. The practical gold standard is to give the patient this genetic testing. But if genetic testing is not available, then you just measure the abdominal girth. If the abdominal girth is normal, it means that no treatment is required. If the abdominal girth is abnormal, you need some treatment, or the further selecting the patient for the genetic testing. What I want to mean this is. Thank you.
Thank you, sir, for that comprehensive and forward-looking perspective on diabetic kidney disease management. Truly an embodiment of bridging evidence and practice.
Now, from digital intelligence of algorithms, we now turn to the visual intelligence of imaging. Diabetes is a disease of silent progression and nowhere in early detection more transformative than in cardiovascular and renal risk stratification. We welcome Dr. Akansha Singh ma'am to present the role of imaging in early risk assessment.
Good morning, esteemed colleagues. Good afternoon, esteemed colleagues. It is an honor to present at the RSSDI State Diabetes Conference. Today, we explore a major paradigm shift in diabetes care, moving from reactive complication management to proactive early risk assessment. By leveraging state-of-the-art imaging and AI, we can map patient-specific metabolic profile and intercept complications before they manifest clinically. Let's examine how imaging drives this change. Reactive to proactive diabetology, conventional diabetes management relies heavily on systemic biomarkers like HbA1c. While valuable, these markers are blind to localized subclinically tissue injury. A patient with well-controlled HbA1c scan still have a significant subclinical plaque or early retinal damage. Non-invasive imaging acts as a virtual biopsy, revealing early structural and functional alteration. This shift is critical for improving long-term patient outcome. Subclinical complication in type 2 diabetes. To understand the scale of the problem, let us look at the epidemiology of subclinical complication. Landmark studies include the DIAD trial show that up to 40% of asymptomatic patients with type 2 diabetes have a silent coronary artery disease. Similarly, conventional renal marker miss up to 30% of early diabetic kidney disease cases. This massive diagnostic gap makes targeted imaging-based screening a clinical mandate. Molecular pathway of imaging, detectable tissue injury. Understanding the pathophysiological basis of what we see on imaging is crucial. The cascade begins with chronic hyperglycemia and insulin resistance, driving oxidative stress and advanced glycation in product. These molecular chains cause endothelial dysfunction and microvascular rarefaction. Over time, tissue hypoxia and chronic inflammation lead to structure remodeling, directly translating into macroscopic changes detectable on scan. Overcoming the limitation of soluble biomarkers. Why integrate imaging when we already have soluble biomarkers? The answer lies in the distinction between local and systemic pathology. Soluble biomarkers reflect systemic states, but they cannot localize tissue injury or capture regional perfusion deficit. Imaging provides a direct localized assessment of tissue structure and function. Because structural change often precede biochemical abnormalities, imaging allows us to intercept complication much earlier. Renal vasculature, a window to systemic microvascular health. Let us begin with retinal imaging. The retina offers a unique non-invasive window into the body microvasculature, sharing anatomical and physiological features with cerebral and renal vessels. While traditional fundus photography only detects visible lesion, optical coherence, tomography, angiography allow us to visualize individual capillary layer without dye. Early subclinical biomarkers on OCTA include foveal avascular zone enlargement and reduced macular capillary density. Coronary artery calcium scoring. Moving to microvascular assessment, coronary artery calcium scoring via non-contrast CT is one of the most powerful risk stratifiers. The power of 0 is particularly noteworthy. A patient with diabetes and a CAC score of 0 has a low 10-year cardiovascular risk, similar to someone without diabetes. Conversely, SCEC score over 100 places with patient in a high risk category, providing a clear clinical action result for statin. Doppler renal resistivity index, detecting subclinical nephropathy. For renal assessment, we look beyond creatinine and albuminuria to Doppler renal ultrasound. By measuring the blood flow velocity in the interlobar arteries, we calculate the RI. An RI of 0.7 higher indicate elevated microvascular resistance and subclinical diabetic kidney disease, even when urine albumin level are normal. This non-invasive hemodynamic assessment has identified early stage nephropathy. Quantitative pancreatic MRI, ectopic fat and beta cell dysfunction. An emerging area of interest is pancreatic imaging. Ectopic fat deposition in the pancreas or non-alcoholic fatty liver disease is closely linked to insulin resistance and beta cell dysfunction. Using advanced quantitative MRI technique like proton density fat fraction, we can non-invasively measure pancreatic fat. This fatty infiltration triggers localized inflammation and accelerated beta cell apoptosis, driving diabetes progression. Beyond MRI, visceral adiposity and myocytosis via DXA and MRI. We must look beyond BMI, which fails to distinguish between muscle mass, subcutaneous fat, and visceral fat. Visceral adipose tissue is highly atherogenic and metabolically active, driving systemic inflammation. Similarly, ectopic fat infiltration is in skeletal muscle known as myocytosis impairs glucose uptake. Using DXA or MRI, we can precisely quantify this fat deposition to design targeted lifestyle and pharmacological intervention. AI integration, transforming pixels into predictive insights. Artificial intelligence and machine learning are transforming how we interpret medical images. AI algorithms automate the segmentation and quantification of complex imaging biomarkers, reducing reader variability. Radiomics extract high-dimensional quantitative features invisible to the human eye. By integrating these imaging features with clinical, biochemical, and genetic data, ML classify generate highly accurate personalized risk prediction. Retinal imaging is at the forefront of clinical AI integration. FDA approved autonomous AI systems like IDXDR are already used in primary care for diabetic retinopathy screening, but retinal AI capabilities extend beyond retinopathy. By analyzing subtle microvascular features, these models predict systemic risk, including stroke, myocardial infarction, and chronic kidney disease, reducing specialist burden and lowering healthcare costs. An exciting application of AI is opportunity screening. Millions of CT scans are performed annually for non-cardiac indication. AI algorithm can analyze these existing scans to extract valuable metabolic risk markers without additional imaging. In a single CT, AI can automatically calculate coronary calcium, measure liver fat, and assess visceral adiposity, identifying high-risk patients who might otherwise go unscreened. To achieve true precision medicine, we must synthesize diverse data streams. Multimodal machine learning model combine clinical variable, genetic risk scores, and multi-organ imaging biomarkers. As shown in the ROC curve, integrating these data domains significantly improve predictive accuracy, with the multimodal model achieving an AUC of 0.89. This comprehensive risk assessment provides clinicians with a powerful decision support. Imaging guided therapy. How does this imaging guided approach translate into clinical practice? It allows us to transition from generic treatment algorithm to precision pharmacotherapy. For instance, if we detect a high coronary calcium score, we initiate high-intensity statin, aspirin, and GLP-1 receptor agonist. If we find an elevated renal resistive index, we prioritize SGL2 inhibitor. This structured approach ensures our therapies match specific tissue pathology. Case study 1. This case shows how imaging guided therapy works in practice. Our patient, a 52 years old male with well-controlled diabetes, was asymptomatic. Traditional risk calculator placed him in a moderate risk category, but a coronary CT angiogram revealed a high risk non-calcified vulnerable plaque. We intensify his therapy with high intensified statin, aspirin, and semaglutide. A 12-month follow-up showed plaque stabilization, preventing a potential accurate coronary event. Case study 2. Our second case involves a 48 years old female with diabetes. Her renal biomarker were normal. However, a renal Doppler ultrasound showed an elevated RI of 0.74, indicating early microvascular nephropathy. We initiated dapagliflozin and optimized her ACE inhibitor. Within 9 months, her renal RI normalized to 0.68, demonstrating how Doppler ultrasound detects early microvascular decline, allowing early intervention. While advanced imaging offers clear benefit, we face practical and ethical challenges. High-end imaging is expensive and often inaccessible. We can mitigate this with risk stratifier, reserving advanced imaging for high-risk patients. We must also minimize radiation exposure using low-dose protocol and non-ionizing modalities. Finally, with AI, we must ensure data privacy, address algorithm bias, and maintain human oversight. Looking to the future, precision diabetology is incredibly exciting. We are moving toward molecular imaging and theranostic. Researchers are developing specified PET stressor to image functional beta cell mass. Smart nanoparticles are being designed to deliver localized therapeutic agent to damaged tissue. This integration of diagnostic and targeted therapy, known as theranostic, we allow real-time monitoring of treatment efficacy. Key takeaway from clinical practice. This is to conclude here are the key takeaway for clinical practice. First, integrate OCTA screening for early microvascular changes. Second, use coronary artery calcium scoring to guide primary prevention. Third, deploy Doppler renal resistive index for early nephropathy detection. Finally, embrace AI-driven tool to the scale screening. By adopting this imaging guided framework, we transition from reactive to proactive metabolic interception. Thank you.
Thank you, Dr. Akanksha, for your nice presentation. And you have very well discussed about role of imaging techniques and AI for early diagnosis of complications of diabetes. Now the questions are welcome from the audience. Any question? Thank you.
Thank you, ma'am, for demonstrating how imaging is evolving from a diagnostic tool into a precision risk stratification instrument, further cementing the role of technology in our clinical armory.
We now move into perhaps the most transformative domain of modern medicine. Artificial intelligence is no longer a distant promise. It is actively reshaping how we diagnose, stratify risk, personalize therapy, and predict outcomes in diabetes. We request Dr. Mahendra Sir, General Medicine, NMCH, and the organizing secretary of this conference to take the podium and present AI in diabetes.
Good morning, everybody. On behalf of the organizing team of the RSSDI Midterm Conference of Bihar chapter, I am very much delighted to welcome you all here. And I am today will be presenting my talk on the artificial intelligence, uses of artificial intelligence in diabetes care. Yesterday in the inaugural ceremony, we have already discussed about artificial intelligence in depth by our various eminent speakers. Some has discussed about the pros of the artificial intelligence used in the diabetes care, whereas some have discussed the cons of it. So today in my talk, I will be discussing how artificial intelligence transforms diabetes care and how it can be utilized in the prevention, diagnosis and management. Now, coming to the diabetes, it is a global epidemic, and almost it has 537 million adults living with diabetes as far as the data of 2021 states. India's burden is about 74 million, which is affected population of diabetes, and it makes it the highly prevalent global area with this much of population, and it has future projections of about 783 million globally till 2045. So the annual global cost of healthcare in diabetes expects up to $327 billion, which is too much. So why artificial intelligence matters in diabetes care? Once we talk about care of diabetes, we have clinical decision making, how to treat the patients by our decision making, and determining the treatment options. So diabetes management requires relentless daily decisions across multiple domains, including diet, medication, lifestyle, overwhelming human cognitive capacity. Severe shortage of endocrinologists is there, and for that we have to train different types of clinicians, not only clinicians, apart from clinicians, other faculty members also, other type of healthcare providers, especially in resource limited settings. And we have limited pattern of specialized care in diabetes. So the growing complexity of personalized treatment, optimization, and polypharmacy requires advanced computational tools to identify the best therapeutic pathways in diabetes. We have also the opportunity where we use AI to diagnose the diabetes early. So AI can be used as a clinical amplifier, not as a replacement to the healthcare. AI is designed to augment and not replace healthcare physicians, and their expertise and judgment are at the utmost. AI helps to extend the reach of the population, healthcare to the general population where we cannot reach generally through telemedicine and through other screening methods. It also enhances our judgment capacity. Now, with the help of AI, we can also give scalable care to different types of population. So, AI with physicians' expertise, we can give a superior patient we can have a superior patient outcomes. So, what is artificial intelligence in healthcare? We have the computer systems which are performing different types of tasks. Now we have also developed different type of computer systems which have human-like intelligence. The generative AI is a typical example of it. Then we have the machine learning algorithms that allow systems to learn, improve from data without explicit programming. And then we have the deep learning curves. The use of generative AI is best clinical example where many of our postgraduate students are used to by taking their clinical notes and generating the summary, patient summaries over that. Detection of X-rays and extracting the relevant reports from them is the use of deep learning, where the different types of neural networks are used, and they perform the diagnosis on the basis of previously designed or previously fed data. Then we have machine learning, which have different types of neural networks combined and it learns on the basis of data provided, and it is a process of continuous learning where the new data is also integrated into it and the learning continues. We have risk assessment protocols designed by AI for that, and then we have virtual assistants which help us. Now the use of machine learning. One thing is use of machine learning. We have one black box type of thing, which once data is fed and the outcome is gained. But now we have developed artificial intelligence to such an extent where machine is already learning based on the recent data. So we have label training data which predicts the outcome, where we have diabetic risk prediction scores made by the artificial intelligence. Then we have unsupervised patterns where patient phenotyping is done, and the finest part is the reinforcement learning where the AI learns from the patient data itself. Then we have the use of deep learning and neural networks. For example, we use this in diagnosing the diabetic retinopathy for image analysis, and this uses the transformer networks, recurrent neural networks and convolutional neural networks, where the patient's data or image is uploaded, there is deep learning analysis, it forms an automatic report, and it helps the clinician to take the action on this. So, uses of artificial intelligence in healthcare of diabetes. One is the diabetic retinopathy, where AI achieves 95% plus sensitivity in detecting microaneurysms and exudates. We have FDA authorized systems that IDX-DR or IART, which enables autonomous screening in primary care. For kidney disease screening, we have AI-powered imaging analysis for early nephropathy detection. Early diabetes detection softwares are also present, which have predictive algorithms identifying at-risk population before the onsets. So AI screening expands access to the specialist level diagnostic and resource-limited settings. Second domain is the closed-loop insulin drug delivery system. We have artificial pancreas systems, having automatic insulin dosing based on the continuous glucose trends. We have already learned from our eminent speaker, Rajesh Kesri sir, where he discussed the differences of continuous glucose monitoring and general blood glucose tests which we have done. We have also hybrid closed loop algorithm systems which also have meal announcement included in it. We have fully automated system which predicts the glucose excursions and adjusts insulin autonomously, and the consistent 0.5 to 1% of the HbA1c reduction is generally achieved with few hypoglycemic episodes when we used all these things. Continuous glucose monitoring system, which already we have discussed in the second lecture today. We have in India at present free style libraries already available, which have 15 days of continuous glucose monitoring system, and on the physician's dashboard we can also look over it. The third domain is our glucose prediction, where time series forecasting, predicting the glucose levels almost 15 to 60 minutes ahead using historical continuous glucose monitoring data. We have also personalized models accounting for individual metabolic patterns and insulin sensitivity. Also, we have the data which predicts the impact of the meal on the glucose. So coming to the personalized treatment selections, we have pharmacogenomics and precision dosing. The genetic profiling of the patient is done by the AI, and the patient genomes are used to predict the individual responses to the specific anti-diabetic agents. We have efficacy prediction algorithms which determine whether a patient will respond better to an SGLT2 inhibitor or GLP-1 receptor agonists. We have also adverse event avoidance by prediction through these AI models. We have precision dosing specialization by these AIs, where the dynamic optimization, multimodal data fusion and phenotype matching is done to specify the dose of the patient according to his blood sugar levels. Now, also we have wearable integration, where combining the CGM systems with heart rate, sleep, activity metrics from the use of smartwatches. So CGM sensor is there, insulin pumps are there, smartwatches, activity trackers, all that combined, AI platform combined, and we have to receive the real-time alerts We can have the glucose predictions. We have different lifestyle insights on the basis of that. And after that, when all the data reaches the physician's dashboards, then the treatment adjustments are done on the basis of this. Now coming to the complication screening, we have already discussed in our radiological lecture of screening of the diabetic retinopathy and nephropathy in the previous lectures. We also have a screening of the neuropathy and cardiovascular risk prediction, which has already been discussed in previous lectures about this. And finally, one of the major thing which we have discussed is the clinical decision support systems. Presently, government is also trying to develop a clinical decision support system on the basis of data they are procuring from the PMJY patients at AIIMS New Delhi. And different guidelines are integrated into it. Indian guidelines, American Association guidelines, or we have the RSSDI guidelines which have the recent data, and on the basis of that we have the clinical decision support system built. There are many artificial intelligence software already in place, such as Glass AI, which also integrate the detailed clinical decision support. We have also polypharmacy management can be done through clinical decision support systems. We can also have the risk certification of the patients. So the CDSS acts as an intelligent safety net at the point of care. By synthesizing vast amount of patient data in real time, it reduces the cognitive load on the physicians and minimizes clinical inertia. Studies have shown that AI-driven CDSS improves timely treatment intensification by up to 40% compared to the standard care workflows. Next domain is the engagement of the patient and its lifestyle. The conversational AI NLP-driven chatbots provide a 24/7 patient support, triage symptoms, answer routine queries, and offer immediate dietary guidance based on the clinical protocol. The algorithms can also deliver hyper-personalized nudges based on the real-time CGM and activity data to encourage the physical activity and reinforce healthy eating habits. The monitoring of the adherence to the treatment can also be done by the use of AI. So what are the clinical outcomes which we gain from integrating the AI in healthcare systems? First, AI-assisted care demonstrates the superior HbA1c reduction compared to the standard care protocols. There is complication screening, automated diabetic retinopathy screening, which achieves near perfect detection rates, significantly outperforming manual grading. We also have predictive algorithms which reduce the hypoglycemic episodes by 30%. And AI-driven patient engagement tools substantially improve medication adherence. Now we have the black box problem, which is a very big challenge for us, because the AI gets the input data and it gives the output data, that is the decision. But what happens in between, we don't know. That is the biggest challenge for us. So now we have to proceed our next generation of artificial intelligence towards explainable AI, because now the AI systems don't explain why they are doing these things or why they are giving this decision. The explainable AI will define the gap and will help to reduce this gap, and the development of these XAI systems will bridge this gap by making the complex model decisions interpretable to human clinicians, fostering trust and safety. There is also algorithm bias, because many systems have used many different guidelines, and they are based on the different types of softwares and systems. There is the training of different systems of AI have been done on different types of data. So many of the times the results do not match. So we have to now proceed towards the equity in the results. So localized validation, mandatory clinical validation of AI tools on diverse local Indian data sets before widespread clinical deployment, and collaborative model training across multiple regional institutions to ensure data diversity without compromising patient privacy. So implementation barriers are there. There is integration, workflow disruption while integrating these AI models into the routine. We have excess notification, which also fatigues the patients as well as the clinicians. We have the trust deficit because we have the lowest transparency in the algorithm, that is the black box thing. We have also infrastructural problems where EHR are not connected. Then data quality, many of the data is incomplete, the records are very much messy. There is digital divide where many of the systems do not have proper hardware, or many many places we don't have the broadband connectivity still in India. So we have also the regulatory compromise here. There is no regulations which will drive the use of AI in healthcare systems. Also, patient privacy, cybersecurity, data ownership are also the challenges which we have to face. Clear ethical frameworks are not framed till now, that the AI generated insights will be owned by whom, either by the patient or the clinician or the AI company, who will own the results. Cybersecurity is also a major problem because the connected devices, closed loop insulin pumps, they can be hacked at any time. Patient privacy is always at risk. So the explainable AI techniques, the SHAP values which quantifies the HbA1c, age, BMI, these don't have strict, while training of the software, we don't have the data privacy of the patients. We have to give all the data to it. The LIME, the black box model, and the decision trees are used inherently, which are interpretable. But although they provide a clear vision, but these should be monitored closely. So now coming to the regulatory landscape and guidelines, the ADA ADA and FDA has approved the AI system for diabetic retinopathy screening and emphasizes the need for continuous validation of the AI-driven closed-loop systems. WHO focuses on the use of ethical use of the artificial intelligence in healthcare, stressing transparency, equity, and prevention of the algorithm bias in global diabetes management. RSSDI also advocates for the integration of artificial intelligence in the Indian clinical practice, specifically highlighting the need for algorithms trained on local diverse phenotypic data. FDA regulation classifies artificial intelligence and machine learning models as a medical device, which are also called as SAMD, and requires rigorous clinical evidence and post-market surveillance for autonomous diagnostic tools. So the successful implementation, how we can implement successfully this all, despite these all flaws, AI into the diabetic care. Now, the FDA has authorized artificial intelligence in diabetic retinopathy screening. In 1 to 2 years, we can integrate artificial intelligence as risk production into the primary health care. In next 2 to 3 years, we can deploy the AI clinical decision support system as per RSSDI 25 guidelines and recommendations. In next 3 to 5 years, we can establish an AI integrated diabetes care ecosystem in India. So the RSSDI call to action, the local data ecosystems, we have to collect data from the local ecosystem, we have to integrate it clinically to make a CDSs, and we have to train healthcare professionals, that is the capacity building for their AI literacy and using the AI in diabetes care. Near-term opportunities, we can have 25 to 27 goals, the integration of the large language models with the EHRs. We have to extend the prediction horizons, moving beyond 60-minute glucose forecasting to multi-day risk predictions and federated learning networks. Medium-term vision 27 to 2030 through RSSDI, multimodal data fusion, autonomous systems, and applied pharmacogenomics can be used by implementing the artificial intelligence in the diabetes care. Long-term transformation post 2030, we can have the digital twin technology, in silico patient models to personalize and optimize therapy, health equity artificial intelligence tools that detect and reduce the systemic care disparities, and population scale prevention, predicting and preventing diabetes at population level. So AI will ultimately transform diabetes from a managed chronic condition to a predictable and preventable disease. Thank you.
Thank you, Dr. Mahendra. You have explained very well role of AI in management of healthcare system, and medical education. You have also explained very well role of AI in management of diabetes. But AI, as you said, AI has pros and cons. It doesn't have human touch. It's just a machine, and what data you feed, on that basis it gives its result. एक न्यूज़ आया था जिसमें कि मारुति के कंपनी में रोबोट काम कर रहा था और उसने कर्मचारी को उठा के पटक दिया, उसका वहीं पर डेथ हो गया. तो थोड़ा सा इसमें ह्यूमन टच होना चाहिए. सो एआई कैन नेवर रिप्लेस क्लिनिशियन.
हमने सबसे पहले वो बोला
it
is just to augment the
yes, AI is here there to help us. जैसा कि अभी डॉक्टर आकांक्षा ने भी टॉक किया, बताया कि अभी इमेजिंग टेक्निक्स का बहुत सारा रोल है और ये हम लोग को हेल्प करने के लिए है, लेकिन बट इट कैन नेवर रिप्लेस. सो ऑलवेज क्लिनिशियन का काम क्लिनिशियन को करना ही पड़ेगा, और एआई जितना भी टेक्नोलॉजी आ रहा है, जो भी है, दैट इज जस्ट टू हेल्प अस. सो विद दीज वर्ड्स, so any question?
Okay, thank you, sir.
A sincere vote of thanks to Dr. Mahendra Pratap sir for illuminating the extraordinary intersection of machine intelligence and clinical diabetology. As sir rightly said, AI is not replacing the physician. It is empowering us to do more, see more, and care better.
So as we draw session 9 to a close, we wish to place on record our deepest gratitude to each of our speakers.
We also extend our sincere thanks to our distinguished chairperson, Dr. Jitendra sir and Dr. Ranjan sir, for their expert moderation and academic stewardship.
A warm thank you to our esteemed delegates. Your engagement and your presence is what like its true academic vitality.
We now request our esteemed chairperson to felicitate the speakers. Dr. Adnan Imam,
Dr. Angad sir,
Dr. Akansha ma'am,
Dr. Mahendra sir,
can I now request the members of our organizing committee, Dr. Rana sir and Dr. Narendra sir, to facilitate our esteemed chairpersons.
thank you. I now request Dr. Mahendran sir, the organizing secretary of this conference, to give the valedictory speech.
First we will have the paper and poster presentation, and after that we will have the valedictory session. So all the postgraduates are requested to go upstairs in hall B for paper and poster presentation.